ceria berseri 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni Smile 5,0 membawa inspirasi. Senyumlah selalu ceria berseri 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni Smile 5,0 membawa inspirasi. Senyumlah selalu ceria berseri 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni Smile 5,0 membawa inspirasi. Membawa inspirasi. Senyumlah selalu ceria berseri 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni Smile 5,0 membawa inspirasi. Senyumlah selalu ceria berseri 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni Smile 5,0 membawa inspirasi. Senyumlah selalu ceria berseri 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni Smile 5,0 membawa inspirasi. Membawa inspirasi. Senyumlah selalu ceria berseri 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni Smile 5,0 membawa inspirasi. Senyumlah selalu ceria berseri 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni Smile 5,0 membawa inspirasi. Senyumlah selalu ceria berseri 20 gigi di usia 60 nanti. Senyumlah selalu ceria berseri. Senyumlah selalu ceria berseri 20 ceria berseri 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni Smile 5,0 membawa inspirasi. Senyumlah selalu ceria berseri 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni Smile 5,0 membawa inspirasi. lalu ceria berseri 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni Smile 5/0 membawa inspirasi. Senyumlah selalu ceria berseri 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni Smile 5/0 membawa inspirasi. Senyumlah selalu ceria berseri 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni Smile 5/0 membawa inspirasi. Membawa inspirasi. Senyumlah selalu ceria berseri 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni Smile 5/0 membawa inspirasi. Senyumlah selalu ceria berseri 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni Smile 5/0 membawa inspirasi. Senyumlah selalu ceria berseri 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni Smile 5/0 membawa inspirasi. Membawa inspirasi. Senyumlah selalu ceria berseri 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni Smile 5/0 membawa inspirasi. Senyumlah selalu ceria berseri 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni Smile 5/0 membawa inspirasi. Senyumlah selalu ceria berseri 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni Smile 5/0 membawa inspirasi. Membawa inspirasi. Senyumlah selalu ceria berseri 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni Smile 5/0 membawa inspirasi. Senyumlah selalu ceria berseri 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni Smile ceria berseri 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni Smile 5.0 membawa inspirasi. Membawa inspirasi. Senyumlah selalu, ceria berseri 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni Smile 5.0 membawa inspirasi. Senyumlah selalu, ceria berseri 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni Smile 5.0 membawa inspirasi. Senyumlah selalu, ceria berseri 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni Smile 5.0 membawa inspirasi. Membawa inspirasi. Senyumlah selalu, ceria berseri 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni Smile 5.0 membawa inspirasi. Senyumlah selalu, ceria berseri 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni Smile 5.0 membawa inspirasi. Senyumlah selalu, ceria berseri 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni Smile 5.0 membawa inspirasi. Membawa inspirasi. Senyumlah selalu, ceria berseri 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni Smile 5.0 membawa inspirasi. Senyumlah selalu, ceria berseri 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni Smile 5.0 membawa inspirasi. Senyumlah selalu, ceria berseri 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni Smile 5.0 membawa inspirasi. Membawa inspirasi. ceria berseri, 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni, Smile 5,0 membawa inspirasi. Senyumlah selalu, ceria berseri, 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni, Smile 5,0 membawa inspirasi. Senyumlah selalu, ceria berseri, 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni, Smile 5,0 membawa inspirasi. Membawa inspirasi. Senyumlah selalu, ceria berseri, 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni, Smile 5,0 membawa inspirasi. Senyumlah selalu, ceria berseri, 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni, Smile 5,0 membawa inspirasi. Senyumlah selalu, ceria berseri, 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni, Smile 5,0 membawa inspirasi. Membawa inspirasi.
From the young to the wise across the miles, we're building a community of healthy smiles. Knowledge and care walking hand in hand, spreading the joy across the land. So keep that smile bright and free. 20 at 64, you and me. Generations together, shining so bright. Smile 5.0, bringing the light. masyarakat bersama harmoni. I untuk ideal, impian di hati, L untuk lancar, senyum setiap hari. I untuk ikuti, kasih diberi. Senyumlah selalu, ceria berseri. 20 gigi di usia 60 tentu nanti.
Senyumlah selalu, ceria berseri. 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni. Smile 5,0 membawa inspirasi.
So, Assalamualaikum. Bersama kita lagi dalam program Community Smile 5.0, Format di Sabak Bernam. So, hari ini kita berada di Dewan Pusat Khidmat Masyarakat Don Sabak untuk program Community Smile yang akan membawa pelbagai aktiviti menarik dan juga informasi kepada pengunjung lah. So, apa itu Smile? So, Smile adalah satu program komitmen Fakulti Pergigian UiTM dalam membawa ilmu, kepakaran dan perkhidmatan kesihatan lebih dekat kepada masyarakat secara berterusan. So, kenapa kita pilih Sabak Bernam hari ini? So, statistik 2025-2026 Selangor merupakan negeri yang mencatatkan jumlah warga emas tertinggi di Malaysia. So, dan specifically kepada Sabak Bernam mempunyai peratusan warga emas tertinggi dekat negeri ini mengikut nisbah warga emas berbanding jumlah penduduk daerah. So, 21% ke 25% adalah warga emas.
Dalam bahasa Inggeris dia functional ability.
Hadapi oleh tuan-tuan dan puan-puan berkenaan pergigian.
Dan juga cara memberus gigi dengan cara yang betul. Jadi hari ini nanti cikgu akan pegang ni gigi.
Dan kita boleh gaulkan dia, tapi sebelum tu saya letak sikit parutan limau nipis. Dia punya biji, dia punya kulit dia je.
Okey, dan di sini juga ada simulasi survey. Kami akan tanya beberapa soalan berkaitan dengan risiko jatuh lah.
Lepas tu yang satu lagi terrorism, kami panggil selaput luar lah. Selaput luar.
Banyak komponen. First day ialah BMI. BMI ni kita nak tengok lah.
Memperkasakan kesihatan komuniti.
Kita rasa seronok, banggalah boleh dapat sertai sekali dengan ni kan. Itu dekat kawasan kita boleh ada macam ni, alhamdulillah lah. Happy lah dengan program-program ni kan. Sertai
Saya memang sangat menyeronokkan lah, segala input-input yang diberikan sangat memberangsangkan.
Dah tengah-tengah program ni nampaknya dah crowd ramai datang ya, penuh Dewan tu. Meriah lah, nampak memang meriah dan sambutan cukup baik lah. Saya harap lah program seperti ni untuk kawasan-kawasan luar bandar macam Sabah Benam ni cukup bagus lah. Ya, sekurang-kurangnya fokus kepada warga emas terutamanya, banyak yang hadir dan dapat maklumat-maklumat, walaupun gigi kita ni kadang-kadang setengah pihak tak berapa ambil kisah. Kalau dah pakai gigi palsu dah kira dah okey, tapi sebenarnya banyak dari segi penjagaan dan penambahan baikan ya untuk keselesaan lah kesedaran hidup. Bila gigi sehat, alhamdulillah semuanya akan berjalan lancar.
Kalau kita nampak sepanjang live hari ni memang sambutan sangat menggalakkan daripada warga emas khususnya. Warga emas di Sabah ini kita boleh katakan sangat aktif dan cergas lah mereka memang terlibat dalam aktiviti memasak, aktiviti karaoke pun ada. So kita akan bersiaran seterusnya. Okey.
Welcome to the Faculty of Dentistry, University Technology Mara, where innovation meets compassionate care. Our mission is to nurture future-ready dental professionals through world-class education, cutting-edge facilities, and a culture of lifelong learning. Hands-on clinical training begins early, ensuring our students gain the skills and confidence to deliver excellent patient care and serve communities across Malaysia and beyond. We lead research in oral health sciences, embracing technology and innovation to advance dental medicine and improve quality of life. With global partnerships and award-winning academics, UiTM Dentistry stands at the forefront of dental education in the region. We are proud to introduce our Dean and our Deputy Deans, whose vision and dedication continue to shape the future of dental education. Join us in shaping the future of oral healthcare. Faculty of Dentistry, University Technology Mara, carving the future leaders of dentistry.
Bismillahirrahmanirrahim. Assalamualaikum. Good morning. Salam Malaysia Madani. Salam UiTM di hatiku. Welcome to Smile 5.0 webinar and podcast series organised by the Doctor of Dental Public Health Program, Faculty of Dentistry, University Technology Mara, UiTM. As Malaysia moves towards becoming an aging nation by 2030, the importance of the healthy aging never been greater. So, guided by this year's theme, Empower Older Adult, Inspiring Generation, Smile 5.0, aligned with the Malaysia Healthy Aging Agenda and National Policy for the Older Person. It also supporting Ministry of Health Malaysia 2060 aspiration. So today, we begin with our first webinar entitled The National Imperative, Aged Nation by the 2048. Why a healthy aging society is a national health and economic priority. To guide us through today's discussion, it is my pleasure to introduce our moderator, Dr. Nonuha Muhammad Nazri. I would like to invite everyone to participate actively, and if you have any question, please submit them via the YouTube live chat. Before I hand over the session, let us take a moment to watch Smile 5.0 video teaser.
Apakah yang paling penting untuk menjalani kehidupan yang baik apabila semakin berusia?
Kesihatan yang baik, sokongan keluarga dan kehidupan yang selesa.
Adakah kesihatan gigi dan mulut penting bagi warga emas?
Ya, supaya kita boleh makan, bercakap dan tersenyum dengan yakin.
Okey, pada pendapat makcik, apakah maksud menua dengan sihat?
Badan sihat, boleh berdikari dan terus aktif.
Okey, pada pandangan pakcik pula, adakah Malaysia sudah bersedia menghadapi pertambahan warga emas?
Pendapat saya rasanya macam sedang bersedia. Tapi banyak lagi yang perlu dibaiki.
Malaysia is changing. This country is on the move towards becoming an aged nation by 2048. One important question remains: are we truly prepared? I'm Dr. Nur Noha, your moderator for the first webinar of Smile 5.0 program. Join us as we discuss one of Malaysia's most important national priorities, the national imperative, Aged Nation by 2048. Why a healthy aging society is a national health and economic priority, featuring 3 distinguished experts. Exploring healthy aging from the perspectives of health policy, health economics, public health, and oral health. Join us on 20th of July 2026 from 9:30 a.m. to 12 p.m. Malaysia time, live on YouTube at Smile UiTM 450. Be part of the conversation.
Assalamualaikum warahmatullahi wabarakatuh. Thank you to Dr. Shafrina, and a very good morning to our distinguished panelists and all participants. Welcome to the first webinar of the Smile 5.0 program entitled The National Imperative Aged Nation by 2048. Why a Healthy Aging Society is a National Health and Economic Priority. As Malaysia moves towards becoming an aged nation, this discussion is increasingly important. It reflects the wider purpose of Smile 5.0, which carries the theme Empowered Older Adults Inspiring Generations. Today's webinar marks the beginning of this important series and provides a platform for us to explore population aging in Malaysia. It also invites us to consider why healthy aging should be viewed not only as a healthcare concern, but also as a national health, economic, and social priority. We are honored to have 3 distinguished panelists with us today, bringing valuable expertise in dental epidemiology, public health, health economics, and health policy. Their insights will help us better understand why healthy aging, including oral health, must be recognized not only as a matter of individual well-being, but also as a national priority linked to healthcare sustainability, economic resilience, social development, and measures preparedness for an aged nation. At this point, allow me to introduce our distinguished panel members. First, it is our great honor to welcome Professor Emeritus Datuk Dr. Syed Muhammad Al Junid bin Syed Junid, public health medicine consultant and professor of health economics, policy and management at University Kebangsaan Malaysia, and professor of community medicine at IMU University. Professor Dato is one of Malaysia's most influential figures in health economics and health financing, with over 3 decades of contributions at national and international levels. He was the first Malaysian to earn a PhD in health economics and financing from the London School of Hygiene and Tropical Medicine, and his pioneering work in case mix and DRG system has shaped provider payment mechanisms in more than 20 countries. He has authored over 300 scientific publications, delivered more than 350 presentations, and in 2025 was recognized among the world's top 2% most cited scientists by Stanford University. We warmly welcome Professor Emeritus Dr. Syed Muhammad Al-Junaid to today's panel. Our second panel member is Mr. Azrul Muhammad Khalid, founder and chief executive officer of the Gallant Center for Health and Social Policy, as well as CEO at the Faculty of Dentistry, University Technology Mara. With a background in genetics and public health policy, Mr. Azrul has more than 22 years of experience as a development, program, and policy specialist. His work covers a wide range of strategic health system issues, including access to healthcare, sexual and reproductive health, HIV and AIDS, gender-based violence, and humanitarian assistance. We are pleased to have Mr. Azrul with us today. Completing our distinguished panel, it is a particular privilege to welcome Emeritus Professor Murray Thompson from the Faculty of Dentistry, University of Otago, New Zealand. Professor Thompson is an internationally respected academic and a leading authority in dental epidemiology, gerodontology, and oral health services research. His work has significantly advanced our understanding of oral health across the life course, particularly its relationship with aging, function, and quality of life. Through his long-standing involvement in the renowned Dunedin Multidisciplinary Health and Development Study, he has contributed valuable insights into the long-term development of oral health from childhood into later adulthood. He has also provided international leadership in evaluating the effectiveness of dental care and its impact on the health and well-being of children and their families. Professor Thompson currently serves as editor-in-chief of Gerodontology and has dedicated many years of editorial service to leading international journals. We are truly honored to have him join us from New Zealand to share his expertise today. And we are privileged to have all 3 distinguished panelists with us today, and we look forward to an insightful and meaningful discussion. We would also like to encourage all participants to take an active role in today's session. Please feel free to share your thoughts and questions through the chat box. Your participation is important as we explore practical ideas and shared responsibilities in preparing Malaysia for an aged nation by 2048. With that, we hope today's discussion will inspire meaningful reflection, stronger collaboration, and collective action towards building a healthier aging society for Malaysia. Before we begin our panel discussion, allow me to briefly set the context for today's webinar. Malaysia's population is aging, a shift driven by longer life expectancy and declining fertility. In simple terms, population aging occurs when older adults make up a growing share of the total population. According to DOSM's latest estimates, the proportion of Malaysians aged 65 and above increased from 7.6% in 2024 to 8% in 2025. Malaysia became an aging nation in 2021, and we are projected to become an aged nation by 2048, when this group reaches 14% of the population. This demographic change extends far beyond healthcare. It affects national productivity, social protection, retirement security, family caregiving, and the long-term sustainability of our economy. With that in mind, today's discussion will move through 3 rounds that explore the national importance of healthy aging, the risk of poor aging outcomes, and how Malaysia can prepare through policy, financing, communication, and oral healthcare planning. To begin, I'd like us to step back and look at the broader national picture. Aging is not only about hospitals, clinic, pensions, or long-term care. It shapes how we plan our economy, how we support family, how we design services, and how we value older adults in society. With that context, I'd like to invite Professor Emeritus Dato Dr. Syed Muhammad Al-Junid to open our first round. Professor Dato, Malaysia is projected to become an aged nation by 2048. From a health economics perspective, why should healthy aging be treated as a national economic priority and not only as a healthcare concern?
Yeah. Thank you, Dr. Nur Nuha, for inviting me to share my views in this very important conference focusing on aging. I think from the perspective of health economics and also health policy, aging population is one of the many factors that might affect the way that our health system is going to operate, and also how we are going to actually use the limited resources that we have within health sector to take care of this golden group of people. We cannot wait until 2048 when we become the aged nation. We are in the process of going through that. In fact, the activities and also the plan and the policy should start from now. We conducted a few studies last few years, and it shows a big sort of impact in terms of the resource use on the aging population. If we do not do anything, it will lead to a lot of problems. Currently, Malaysia spends about 4.75% of our GDP, lower than 5% of GDP, and much lower if you compare to the best practices in other countries. If you compare with OECD countries, they spend probably about double the amount of resources into healthcare. With these limited resources, we have to take care of the whole population, not only the aged. But the older generation or older people have special needs. If you look at the survey that was conducted last year, or in 2025, it was found that around 40 to 50% of our population, aged population, will have at least one, nearly 60% of them will have at least one chronic non-communicable diseases. And with 40% of them, they've got at least between 2 to 4 conditions which are chronic. When we say chronic, it means that it has to be treated or managed long term, and it consumes huge amount of resources. And in our study, which involved, I think, 11 states in Malaysia, and we did a survey about 2,000, more than 2,000 older people. We found that the whole country, if you want to actually spend the appropriate healthcare services, currently the cost of treating and managing elderly population in terms of the healthcare costs has reached around 8 billion per year, which is almost 10% of our total health expenditure. And it was estimated that by 2030, it will reach to about 12 billion ringgit per year, which is around 8% of our GDP. This is a huge amount of resources. And at the moment, a lot of these resources are actually contributed by the government, but we have a big portion where people have to pay on their own, which is what we call the out-of-pocket expenditure, nearly about 38%. And maybe it will go higher than that. And who are the people who actually have to pay out of the pocket? And most of the time, it will be the elderly population, because they are the one who may not have insurance coverage. Many of them are not in a pensionable scheme, and they have to cough out their own resources from somewhere that they can get, especially from their own income and also from the family support. So we need to look closely how we can actually prepare our country to have a lot of enough resources to manage this important group of people, so that we do not want their quality of care or quality of life affected by the inability for them to access the healthcare services. And we must also go back to the concept of universal health coverage. Under universal health coverage, everybody should have access to good quality of care irrespective of their age, their income, and also where they stay. But are we ready for that in this situation? With a high out-of-pocket expenditure and high healthcare costs that incur among the aged population, I think we still have to work a lot more. We have to develop policies that are sustainable in long term to provide services to the elderly. I think that's from me in short. How would I summarize the whole situation? Over to you, back to Dr. Nuha.
Okay, thank you, Professor Dato. You have highlighted that population aging raises not only questions of health, but also affordability, access, and capacity of our public healthcare system. And next, I'd like Mr. Azrul I'd like to move to Mr. Azrul from the economic pressures to the way aging is understood and addressed through policy. Building on Professor Dato's point, how can Malaysia shift its thinking from seeing aging mainly as a cost to seeing healthy aging as a long-term national investment?
Thank you, Dr. Nuhan. Thank you for having me this morning for this very important webinar. I think very timely, but also in some respects overdue, I think, as a nation as a whole. Because this conversation about aging should really have started maybe 2 decades ago to prepare Malaysia for many of the pressures that have been mentioned by Prof. Said Al-Junaid earlier. And this is really because of the group of people that we're talking about who are exceptionally and increasingly vulnerable, especially in terms of the changing economic climate today that we're facing, but also other social pressures that require a certain amount of social protection for institutions to respond to the needs of this particular group. And it's important for us to understand what are we and who are we talking about really to begin with. And this is where I will express a little bit of my concern here, because previous governments didn't take aging seriously enough. And I would argue that even based on our own definition of what is or who is an aging or senior person, so to speak, we find that the definition has changed. If you look at DOSM's own definition of who is included in this category, for the longest time, we've been using above the age of 60. And this is someone who is considered needing much more in terms of services, need specialized care maybe, need to be exceptionally looked at because they are more likely to not work already, because retirement at perhaps when the definition was put out was when people would retire maybe 58 or 59. Therefore, from that point on, you wouldn't have a source of income. Of course, it's different today. Maybe people retire later. But at that point in time, and up until last year even, we were still talking about up to the age of 60, for which, when we talk about age nation status, you mentioned just now, we actually hit it back in 2021 based on the previous definition. And at that point in time, we looked at 11% of the population already being of this particular age. And today, when you look at what we were or are facing, actually, it's 15.3% of the population by 2030, hitting already this definition of aged individuals. So definitions really matter because it looks at how we view this issue with certain amount of urgency, seriousness, on also the need to allocate the necessary resources, which Prof. Said mentioned just now, funding, but also in terms of the need to set up structures to ensure that we're able to care for our age individuals, similar to what we see in South Korea, Singapore, Japan, and so forth. And suddenly last year, Dr. Nuha, we were suddenly talking about above the age of 65. So suddenly we've moved the goalposts, as it were, big World Cup fever still, from 60 to 65. And suddenly we're talking about, I think you mentioned just now, 2048. Because 2048 looks further away than 2030, for which the urgency is much more. And this is very important because the uh, there cannot be an assumption that everybody who is below the age of 65 and 60, between that age are going to be okay. Everything's going to be taken care of. No, nothing's going to be uh, left behind and so forth. And this is where I think we need to relook at these issues. We need to take a serious approach and strategies, look and review the institutions that we have available today. Are they able to provide the kind of care, treatment, and support for this group as we should? And of course, we look at other countries that are already aging, who are around this region. I think, uh, I mean, not to put a stick into it, but I think our region has a very good way of incorporating both community, society, and government in terms of responding to the needs of aging populations. Of course, we can learn from our Western countries' approach to it, but here it's very community-based as opposed to individual-centric in those other countries. So we really should look at some of the examples. For other countries, they have already looked at this problem for decades. We have arguably only truly considered this as an imperative, as you mentioned in terms of this this webinar, only in the past 6 or 7 years. And even the RMK, the national the Malaysia plan, for example. Look at the Malaysia plan. How serious is aging indicated there? Are there resources there? Is there funding to what is being planned and so forth? So it really matters on how we look at this. And I just wanted to mention one last point before I hand it back to you, Dr. Nuha, is that we need to also incorporate inclusivity. I noticed that in our panel today, we don't have any women, and that's a problem. It's a manual. So we're missing out on a significant population because none of us can speak on the needs of women as well as women themselves. So we also need to look at gendering our approach to public health policies as well, to be ensuring that we don't leave people behind either, and to ensure that, especially when we talk about aged care, who are the prime caregivers of aged care? I would argue disproportionately women. And women are taking care of their older people, people who need the kind of community support. Who is there at home taking care of these senior citizens, these aged individuals? It's women. So we really need to have also better representation and inclusivity in terms of how we look at these policies themselves. And we find that sometimes they're not in the room, and we need to have that very much emphasized and mainstream, because it matters on how we look at allocation of resources, the voices at the table, who's sharing their experiences at the table also matter. And I would say that in terms of incorporating this integrated approach, we need also to ensure that we are all on the same page when it comes to this aging issue. I'm just looking at our own personal experiences, our family, and so forth, that I think, contrary to the earlier video, it said that we are prepared. I say Malaysia is actually ill prepared when it comes to dealing or responding to the needs of the aged population. It's still very much dependent on families and private sector. We can and should be able to do more. So I'll start off with that first. Thank you, Dr. Nora. You're muted, Dr. Nora.
Yeah, you're muted, yeah.
Okay, thank you, Mr. Azrul. Sorry for that. Okay, your response highlights that preparing for an aging population requires not only the inclusivity, but also funding, aged care, and of course, the clearer policy direction. So next, I'd like to invite Professor Thompson. First, I'd like to turn to an area that is often underrepresented in the wider healthy aging agenda, which is oral health. So, Professor Thompson, let us talk about oral health. So, from your experience in dental epidemiology and aging, how does oral health contribute to healthy aging, independence, dignity and quality of life among older adults? Sorry, Professor, you have to unmute your mic.
Yeah. Sorry, kia ora. Thank you for including me in this important session, Dr. Nuha. It's been very interesting so far. Yeah, good question. I think when we're thinking about oral health, we tend to have as dentists and people working in oral health, we have a sort of an inferiority complex, I think, in some ways, and we're always trying to relate oral health to broader systemic health, etc. And most of that is pretty fruitless and is not helpful. I think we need to recognize that good oral health is a very important end in itself. And also the modern biopsychosocial approach that we take, that we use in thinking about health and in epidemiology these days emphasizes function over the absence of disease. If we think about the fun stuff that we like to do as older people, you know, the eating, the smiling, the talking, the singing even, the kissing even, you know, to do that with comfort and dignity is a worthwhile aim in itself. Older people who can do those things have better lives. The World Health Organization emphasizes, in its definition of successful aging, it emphasizes functioning rather than the presence or absence of disease. And I've got the WHO definition here, so I'll read it out. It's very short. It's developing and maintaining the functional ability that enables well-being in old age, in older age, I should say. And it's important, you know, you saw with the older people who were interviewed in the opening video, they didn't talk about whether or not they had dental caries or periodontitis or oral cancer or whatever, or dry mouth. They were talking about functioning, basically, and being comfortable and being able to go about their day-to-day lives with dignity and to be able to smile at people, you know. There's a classic paper by Gary Slade and Ann Sanders in the Journal of Dental Research from 2011, with it's called The Paradox of Better Subjective Oral Health in Older People. What they showed quite clearly using Australian National Oral Health Survey data and using Slade's well-known quality of life measure, the Oral Health Impact Profile, they were able to show that when they looked at the OHIP by age group, the older people, the older you were, the better functioning you had, basically. You know, and I think what that shows, and the more comfort, the more comfortable lives, you know, in terms of their oral health people had. And I think that shows the way that older people adapt to their changing circumstances as they go through life. And I think it's a very important thing to realize. I mean, myself, I'm 70 next birthday. I spent this morning running in the trails near my house. You know, I can no longer run a fast marathon, but I can still get out and run in the bush. You know, and that for me is a quality of life issue, and it's likely to make me last longer, I hope, because of my cardiovascular fitness. So, you know, old age and oral health are not incompatible. And if we think about the example of edentulosum, if we view it using the old biomedical approach where, you know, hanging on to your teeth and being able to chew, you know, having no disease is the thing we need to aim for, edentulosum is undesirable. But if you think about it from a functional point of view and from a life course point of view, it depends, because for a lot of people, making the transition to edentulosum at some stage during the adult life course means that they go from a situation of having dental misery to one where they no longer have dental symptoms, you know, and they may have to adapt to complete dentures and learn how to drive them, you know, but for those people, it's actually a positive thing. So I think we need to, when we're thinking about good oral health, we need to think very broadly in terms of what our definition of it is, and to realize that it's not just the absence of disease, not just the absence of tooth decay, gum disease, nasty oral mucosal lesions and dry mouth. It's about function and the way in which people function in their day-to-day lives. I hope that answered the question. Silence.
Okay. Okay, thank you, Professor Thompson. Now we have heard that healthy aging requires good financing, clearer national policy leadership, and recognition that oral health is inseparable from general health, function, and quality of life. So I'd now like to bring these three perspectives together. If, let's say, Malaysia were to take one coordinated step now, how should health financing, policy leadership, and oral health care be brought together to strengthen healthy aging by 2048? Perhaps we can begin with Professor Dato from the health financing perspectives, followed by Mr. Azrul from the policy and public health perspective, and then Professor Thompson from the oral health and aging perspectives. May I ask each speaker to respond briefly in around 2 to 3 minutes?
Okay. All right. Shall I start?
Yeah, sure.
Okay. You asked me about health financing for the elderly. There is actually no good model that available that we can follow at the moment. Malaysia, for example, in the context of Malaysia, we are depending mostly on the taxation as a source of funding. Nearly about 60% of our more than 55% of our resources come from tax, and then the remaining are out-of-pocket expenditure, and then there were about 7-8% which come from the private insurance. So if we depend on just taxation, for example, we know that the amount of resources that goes into the health services is very small. It's just about 2.5% of our GDP. And in our health white paper, which was launched in 2023, I mean, people tend to forget about this health white paper now. The government were encouraged at that time. This health paper come from Ministry of Health. They were suggesting that the government should allocate at least 5% of GDP to of health sector of health services in the public sector. If you combine with the private health expenditure, it will actually boost up to nearly about 7%. But as we know, until today, the health white paper was actually been forgotten. Not much activities being carried out to address all the 4 pillars in the health financing aspect. Countries who have got other form of health financing to top up with the national or the taxation system, like for example Indonesia, Vietnam, Philippines, even our neighbors like Thailand, they launched what we call the social health insurance program. This is one of the source of funding that can be filtered out and given or allocate more recognizable amount of resources for the elderly population. If you depend on private insurance, our elderly population will not be given a priority. In fact, currently the government of Malaysia, our government is introducing what we call the Medi Asas, which is actually the private health insurance for the whole population. And you can see that the premium that are going to be charged for elderly population is nearly about 500 to 600 ringgit. Although the cheapest premium is only 65 ringgit, that's what being told. But then that is not for the elderly. The elderly have to cough out a lot more, and they have to pay maybe as high as 600 ringgit, 500 ringgit to 600 ringgit per month. And this is most of the time out of reach, out of affordability by the aged population. And we also know that nearly 60% of our elderly, our older generations, our older people, they are still have to work, and they are still contributing to the family, because there's no other way for them to actually make a living except for to retire, because they don't have a retirement plan. So in other words, we have to find a better solution than just depending on taxation. to cover the aged population. Countries like Singapore and also Japan, they have introduced the long-term care insurance, which is targeted for the elderly population. But then you need to contribute from nearly about 5 to 10 years before you are eligible to get the coverage from this long-term care. It's not that you can do it overnight, and that is need a long-term plan. So in other words, in terms of health financing, we are, unfortunately, Malaysia is not prepared for that. We are focusing on other things, on other part of the population. People are saying that the health financing, people who are actually planning for Malaysia is try to what we call taking a simplified approach in trying to solve these issues on health financing. They call it the low-hanging fruit, but we cannot be actually talking about low-hanging fruit all the time, because the low-hanging fruit will not actually be a good source of policy to address this aged population. So we still have a lot more to work on from health financing perspective in order to avoid in health economic, we are concerned about what we call the catastrophic expenditure. When more than 10% of the resources, 10% of the family income is used for healthcare. At the moment, the figures that we get being estimated that it is less than 5% of the population. But I think if we go towards look at the elderly population, I think it's very much higher than that. These are things that we want to avoid so that people will not fall below the poverty line because of their health status. And the impact on the aging population is much, much higher than that.
Professor Dato, actually we received a question from the audience. I think it's very interesting question to ask you during this time. This question is from Khairul Fikri Sabri for 813. But Thailand also using general taxation for their source of funding for the universal coverage scheme, right, Prof?
Correct, yeah. So I'm not saying that social health insurance will actually replace general taxation. General taxation should be there. This is for the people who are actually unemployed, for the poor. They still have to be supported by that. Most of the country that actually introduce national health insurance, they still have to get the coverage of certain portion of the resources from the taxation. So it is not to replace that. This is actually additional resources that we are talking about that we need to put it up. We cannot depend all the time on the taxation program. So all the countries, even European countries that have a social health insurance, the taxation part is still there to cover other people who are actually unable to contribute to the national health insurance because of their poverty level, because they are poor, and also because of they are not employed and things like that. So yes, it has to be top up to what we call the taxation program that we have at the moment. Okay.
Okay, thank you, Professor Dato. Next, maybe Mr. Azrul want to add on about from the policy and public health perspective regarding how they should this aspect should be brought together to strengthen healthy aging by 2048.
Thanks, Dr. Nuha. You know, there's something strange happening in Malaysia, really, when you compare to other countries. In other countries, the biggest complaint, especially in aging countries like South Korea and Japan, is that those in power, policymakers, decision makers who are older, are making policies to benefit their group of people, meaning it's very pro-senior, pro-age. You know, there's a lot of resources going there and so forth. I mean, it's a very common complaint. And so in the political spheres over there, they're trying to elect much more younger people so that there's better representation and a little bit of a balance in terms of some of these policies. But for Malaysia, it doesn't seem that way. It's very strange because when you look at the members of parliament today in the Dewan Rakyat, for example, you find that around 62% of MPs above the age of 50. The average age of cabinet minister is around 62, I think. And if you look at the trend lines concerning representation in the cabinet, they seem to be getting older. And so instead of younger or, whereabouts. So compared to the past 10 years, they're getting increasingly older. And yet there's no real dedicated emphasis, commitment to the issue of age until the past couple of years with this government. And that's very important to highlight because it shows that the issues that Prof. Said mentioned just now, especially in terms of affordability and access, really comes into effect because we need policies that are able to level the inequity that's existing right now, to bridge the gap of inequity. Because right now, there's a lot of aged care facilities that are mushrooming like mushrooms after rain. It's a big business now. The care economy is growing. You see more and more places for which they're looking at ensuring there's quality of life, community living for people who are above the age of 65. All of that is great. It's seeing standards of people where they're living the same kind of community living that you see abroad, and they're bringing it here in Malaysia. But the problem here is that a lot of this is inaccessible to people with very little means, or they don't have enough money. It's very private sector centric. And so it walls off the accessibility for the larger part of the population. A lot of the dependencies, policies are dependent on families taking care of their seniors. And when things don't work out right, when there's neglect, where there's abuse, where there are problems in terms of being able to provide the kind of care. And don't forget that when you take care of older people, it actually costs 4 times more in terms of expenditure compared to someone who isn't as in years. And this is something that governments have to factor in as well, because they need specialized care. They need the kind of support system that is able to provide it for a long period of time. Malaysia is fortunate to have a much more higher standard of living. And as a result, there's also better healthcare that's being provided. And so we are living longer today. Dr. Noha, we're living longer today. I think it's the age is around 78 or something in terms of lifespan. And then men is actually lower. We get a few years of discount. We die off sooner. Women are much more longer living. But when you see what happens in the last 10 years of life, and a deputy health minister told me once that a gerontologist told him that the last 6 years or 7 years of life for a senior older person is filled with indignity, misery, suffering, pain. And that speaks a lot to where we are in terms of this issue of aged care. And this is where I'm actually sometimes distressed that we don't hear enough emphasis on this issue by our political leadership, by the people who make decisions, because they are the ones growing older. So by right, they should also be taking care of themselves. But it seems like if you are okay with money, then it's not really a problem for yourself. But this is where we're looking to leadership on this issue. And I'm glad that today's webinar is happening, because it's highlighting, forcing us to think of where we are, look at our families. Are we prepared to take care of them? And my worry right now, Dr. Nuha, is that today we look in legislation, we look at the political space, and it seems that there's now legislation that's intended to punish children for neglecting their elders. And from the surface of it looks good. Good intentions are there, but it's also, road to hell is paved with good intentions. And if you follow this route at the moment, it could be one that is unfair to a lot of people, especially the sandwich generation that we're talking about today. But anyway, I just wanted to mention that in terms of policy and public health, all of this is very much entwined in terms of our ability to access and afford many of these services that we need, especially for the older population. Over to you, Dr. Noha.
Okay. About regarding the legislation, Mr. Azrul, has the bill been passed yet?
It's currently under discussion. And it is being considered in terms of the. We don't want it to be tabled in the way that it would be unfair. So let's not wait for it to be tabled before we input or object to it. We have to be in the conversations right now to ensure that there is fairness, but also a clear understanding of what families, especially Gen Zs and the previous generations are facing today in terms of economic pressure, in terms of the circumstances for which these issues, especially in terms of elder neglect, for example, and abuse happen. So it's very important for us to understand before putting legislation in this way.
Okay. So it's a very interesting point of view, and also what is happening in Malaysia right now. So next, I'd like to invite Professor Thompson to give some your perspective on from the oral health and aging perspective, on how Malaysia this perspective can be brought together with the health financing and the policy and public health perspective. Then it can be brought together to strengthen healthy aging for Malaysia by 2048.
Big issues, big questions. Yeah. I suppose it's important to realize that older people don't suddenly appear. They're there in the population. And right now in the population, the next generation of older people are waiting in the wings, being an older person is a lifelong project. If we think about the life course and its developmental, what we call developmental epochs or developmental stages, you're thinking about infancy, followed by childhood, followed by adolescence, followed by young adulthood, then sort of adulthood, then middle age, and then old age, and then suddenly you're at the end of your life. And that's the life course is our journey from the cradle to the grave. And you think about oral health and oral illness and the common oral conditions. They're chronic, they're cumulative. So as we go through age, we accumulate more and more evidence of how, if you're thinking about dental caries, you can look in someone's mouth and work out their DMFS or DMFT, and that is a cumulative measure of their lifetime caries experience to date in the permanent dentition. And that accumulates, we know now from our work in the Dunedin study, at about one surface per year. So it steadily accumulates through life. Right through into old age, it's still one surface a year. And then if you go into a nursing home as an older person, you can more than double that increment. And if you have dementia, you can more than double that increment. So we end up with a situation where we've got older people in the nursing home sector who are having, if they've got dementia as well, their dentitions are crumbling away. It's important to reflect that the most fundamental determinant of our oral health journey through life is actually childhood cognitive function. And we've shown this in the Dunedin multidisciplinary study. And the reason for that is that brighter kids, children who are more academically successful, end up having easier lives because they get into the professions, or they get into life course trajectories that themselves expose them to fewer bad influences, bad exposures, and they have the wherewithal to be able to manage their own health as they go through life. So if we focus only on what we see in old age when we're thinking about older people and health, we risk misinterpreting what we see, especially if we're also limiting ourselves to the biomedical approach, trying to explain things in terms of the biology of what we're seeing rather than taking a biopsychosocial approach and thinking, well, what are the social influences and constraints and other influences which have led to these disease patterns in older age. And similar principles, apply when we're looking at things like periodontitis and systemic health. Those are both, the NCDs that people are linking to periodontitis are actually occurring and developing through life at the same time as the periodontitis. And what we're actually seeing is that they're both developing side by side. The latest one is tooth loss and dementia, and there's a lot of work out there on that at the moment. And almost all of it has been misinterpreted because people have not used a life course approach. They've tried to tackle what they're observing using a biomedical approach. And so people are, because of that, coming up with unrealistic objectives for oral care. Trying to think, well, let's prevent or treat dementia by replacing teeth. Well, that's not going to happen. The damage has been done. And what we see with older people, the strong association with missing teeth and cognitive function, we can observe it all the way through life. And it's the fact that the childhood cognitive function has determined our health trajectory through life. And children who are less bright have harder lives and they lose more teeth along the way. It's really, really interesting. So when we're thinking about oral health and its place in the wider health system, we've got to be realistic and we've got to think in life course terms in order to explain what we're seeing and to determine the best way forward. I don't know whether I've answered your question, but I hope it's been interesting.
Thank you for that valuable exchange from the panel. So the message is clear. Preparing for an age nation cannot depend on isolated programs. It requires affordability, fairness, access, and political commitment. And it also includes the accessibility, like integration of oral health into aged care, and prevention must begin across the life course as well. So let us now consider what might happen if these changes do not take place in time. So I'll invite Professor Dato. What are the possible economic consequences if, let's say, many Malaysians enter older age with uncontrolled chronic diseases, frailty, cognitive impairment, poor oral health, or reduced functional ability?
Yeah. Actually, we hope that this doesn't happen. But anyway, if we do not take any affirmative action to actually solve this issue, the situation will get worse. We are concerned with the situation where chronic non-communicable diseases are going to affect a lot more people, especially the elderly population. Without a proper mechanism to manage the situation, it will lead to poorer quality of life among the elderly. But we must remember that the health of the elderly will also affect other parts of the population. The family members that have to take care of this is going to consume a lot of their resources, their time, and we are not prepared by that. We really hope that action are taken to avoid this. In our study, we found that about 18% of the aged population are suffering from dementia. And dementia, it creates a lot of stress in the family. We cannot send to anywhere for care, and the family members to take turn. They themselves have to actually be involved in getting their life on, and also works and all that. So these are the things that we found. It is very, very disturbing. We also found that in terms of the conditions like mild cognitive impairment, which is going to be nearer to what a precondition before dementia is as high as nearly 60% of the elderly population. And these are the things that we need to avoid. We have to do proper screening to avoid this happening and take the action before it becomes worse. I think, yeah, we are worried about the quality of life of our elderly population. We want them to actually have a healthy aging, but that is just a slogan in many situations that we saw. But actions have not been taken to achieve this. We really hope that this does not happen in Malaysia in the long term. Yeah.
Professor Dato, your response highlights that poor aging outcomes can affect not only the health and quality of life of older adults, but also access to care and caregiving arrangements, healthcare capacity, and the support required from families and communities. So now I would like to turn to Mr. Azrul. How can public communication shape the way Malaysians understand aging, so that healthy aging becomes a shared national priority rather than only a government or healthcare responsibility?
Thanks, Dr. Nuha. And communication is a very important point here in this discussion because it shapes the way we think, we consider, and we respond to issues like aging. And consider what you just mentioned just now in your question just now, how do we prepare for 2048? That's the wrong question, Dr. Nuha, because the aging situation is already here. It's not 2048. And again, this is where I go back to my earlier point for which I raised the concern that there has been a shift in goalposts on the urgency of aging question, because it's moved from 2030, which is 3 years away, to now 2048, for which it is what 15 years away, maybe 12 years away. Somebody else's problem, possibly another government to worry about, and it's far enough, that it's not the immediate concern. And that in itself is a problem because already the data indicates that today, many of the things that Prof. Said was mentioning just now, he was hoping to not happen. And I think Prof. Ray mentioned also in his own response about how people are being neglected or treated differently and unable to function in their everyday life is already happening. There are people being left behind, people are being neglected, abandoned even. When you look at some of the issues about, I give you example of the festive seasons. I never thought it would actually happen in Malaysia, but it has over the past couple of years, where families are, okay, for lack of a better word, dumping or abandoning their old folks in hospitals during festive seasons because they feel like they can't cope, they can't take care, and they want to focus on just themselves. So they deposit their grandparents or their parents even at hospitals for the duration of the festive season and pick them up after, and so it's somebody else's problem. And in some cases, the abandonment is permanent. They just leave them there, expecting the system to somehow take care of them. So some of the things that Prof. Said mentioned just now that he was hoping would not happen is actually happening today. And even things that we're talking about long-term care insurance, which, I'm in total agreement with the earlier proposal that we need to have a way to finance aged care, because right now, even if you look at the budget, it's not going to aged care, it's going to age welfare. And when you look at aged care, we need a proper budget. We need someone to take responsibility. In other countries, there's even a Ministry of Aging. That's how serious they take this problem. But today, we can't even be sure who's responsible for the issue of age populations in Malaysia. Everybody's, putting themselves into that ministry, that department. It's the welfare department and so forth. So there's some confusion there, because there isn't one sole owner of the issue. So 2048 is just too late. We need today to start thinking about permanent, I think what was mentioned just now, life course solutions. For example, in terms of the financing issue, in some countries, it's at the point of 40 before they ask you to contribute towards long-term care. Unfortunately, in our case, we may even have to start sooner. I'm actually in favor of a national health and social insurance where we collect from most of the population, which contributes towards insurance scheme, which our proposal is that maybe 70% of the funds collected go to health and 30% goes to age issues to ensure that we're able to afford the treatment, the facilities, the community homes, that we want built for there to be something that the government or the authorities are able to manage at the district level or the provincial level or the state level. We need a way to finance this. We need a way to pay for this because too many times, we have an aged care blueprint or care economy blueprint, and there isn't any costing against it. There's no idea as to how much this is all going to cost. People are just proposing it, brainstorming and proposing it. There's no bill and how much to attach. But most importantly, there isn't even an answer as to how do we pay for this. And we need to think about that. If we're talking about life course, it needs to start earlier now, especially since Malaysia started late. And we need to ensure that, unfortunately, we can't take the 14 approach formula. We might have to start sooner. So therein lies, I think, our need to not think about preparing for aged care, but to respond to the needs today, because there are already coming up to 15% of those above the age of 60 already in this country who are going to need the kind of care that we expect for those in the age population. Over to you, Doctor.
Okay. Thank you, Mr. Azrul. Just now you mentioned about the equity in your previous response. So may I know if we prepare late, which groups of older adults are most likely to be left behind?
Well, this is a very interesting question because we expect if you are in the so-called T20, if we're still using those classifications, everything's going to be all right. If you're in the M40, maybe you're going to be all right. And mostly we're going to be talking about those in the lower income bracket that's going to be problematic. But we find that when it comes to aged care, the problem is across society, and it seems like the more well off you are, the more likely maybe you're going to have some neglect there. And it falls back to the individual senior citizen to take care of herself or himself and to be able to do that. They're even mortgaging their own homes to ensure that they're able to finance their care in old age, for example, So never mind about leaving it for their kids or, buying homes, forget it. We all have to take care of ourselves now. But imagine it happening at the lower income level, and this is where we see a lot of this happening, where they're homeless people. And then when you go and talk to them and you see them, you meet with them, you find that a lot of them are in the senior category because their children have abandoned them. They have no place to go. They cannot afford to live in the homes that they've lived in for decades because they rent, they don't own. There's a lot of neglect here where we are closing a blind eye to this issue simply because it's not there yet. Maybe not for anything, but maybe Dr. Noha, you and I, maybe we're not there yet, but our two other panelists here are there, So, and they're fortunate to be okay. But I'm looking at other people as well who may not have the resources, the means, the family, and even the state support. Even, there's some discussion about, you can get money from zakat. You can get from some of these institutions that are able to give you money. How much is that? Maybe they're given, best case scenario, 500 ringgit a month. What can that purchase? What can they get? What can that put a roof over your head? Can that feed you? And for younger people, maybe it's about getting jobs to be able to get a livelihood. It's still possible. But for older people, what happens then? Many of our structures today are actually relics of the past. When the lifespan was at point of 65, for example. People were living shorter lifespans, and so the system didn't have to take on as much burden. Families also would have to take care of their old ones for maybe 5-7 years. Now it could be 20 years, 30 years. And not everyone can be like Dr. Mahathir, who live up to 100, and if that were to happen, we'll be in trouble, but the point here is that the system can't cope with the benefits of a good economy, a good healthcare system, because the people are living longer, but they have less ability and resources to take care of themselves, including families taking care of their older ones as well. So we really need to not talk about preparation anymore, but actually responding to the aged care issue today. Over to you, Dr.
Thank you, Mr. Azrul. When you mentioned about national health insurance, I'm very much interested to ask Professor Dato about, just now you mentioned about the resource allocation and insurance and everything. And so I'd like to know, what would an older adult friendly and equitable financing model need to include, particularly for lower income older adults, especially those who are left behind?
Well, in middle income country like Malaysia, for example, we need to probably think about this, getting a fund that are contributed by employers and employees kind of a contribution. And then this fund can be used to purchase services for the elderly and also for the other population. But I mentioned earlier on, this is to top up what is required for the population on top of the general taxation. It is not just national health insurance. I think people get it wrong when they talk about national health insurance, which means that we're not going to use any more the money that we collect from tax to fund healthcare services. No, that is not the case. We are talking about we do not have enough resources at the moment that would be able to be used to take care of the population, including the elderly population, which probably need a lot more resources because of the disease that they suffer. They tend to suffer from the more severe condition like cancers and all that. I think we have been talking about it for the past 30 years, but I was quite surprised when the current government decided that, I think it was a statement by the government that they are not going to consider national health insurance because it was politically, they say that politically unfeasible. Basically, it is not not feasible. It is actually because of no political will in order to do that. They were very scared that people might refuse to actually contribute to the funding. This is again in contrast with our study. We did a study back in 2019, 2020, and we found that 95% of the population in our study, it was a big scale study, they are willing to contribute between 1 to 2% of their income into a tabung or a funding system for national health insurance scheme. So there's already been willingness to pay among the population because they know that they cannot depend on other form of funding, especially for private health insurance, which is being proposed now as one of the solutions. I think this, when the government announced this, they totally ignore that part of the study, and in fact, they were actually proposing private health insurance to solve this problem. You know, the only country in the world that actually depends so much on private insurance and that almost wreck up the country is basically the US. So are we going toward the situation that US is facing now, where they spend nearly about 17% of their GDP, while nearly about 25% of the population doesn't have any coverage? So we are now focusing on private health insurance, which the government renamed it as MAD Asas, to solve the problem of our health financing needs. Currently, between about 7 to 9% of the total expenditure come from private health insurance. And then, as we know that when the government want to propose this as a solution, we are not going to actually gain much because we are talking about probably 9 to 10% of the population. And with a premium that is unaffordable for most of the population, it will actually create a lot more havoc on the ground. What we are seeing from the health insurance perspective is that if you introduce this insurance, we are further going to break up the pool of the resources that we have. We already have Lindong, for example. It was launched last few weeks, and there was a U-turn. Previously, it was supposed to be mandatory, and now the government said that it's not going to be mandatory, and the SOCSO is now having a lot of issues in order to ask people to apply if they want to be exempted from the scheme, for example. It creates unnecessary bureaucracy and unnecessary resources that being lost because of this poor planning. So when we talk about national health insurance, it has to be mandatory. If it is not mandatory, then it will lead to a situation where only the people who are high risk will join the scheme. Those who are actually at low risk, they will not join the scheme because they will feel they will not be using the scheme. And at the end of the day, we are actually pulling all the bad risks into the pool. And this will actually lead to unsustainability of the financing scheme. So the more private insurance or the more unsustainable scheme are introduced, it will break up more of this what we call pooling of resources. My experience when we were working with Indonesia in 2012 to 2014, Indonesia launched national health insurance in 2014. They have to work really but just to combine all the insurance programs that are already in existence at that time. There are more than 10 different, these are we're talking about public insurance, from the SOCSO, from the EPF, and all other schemes that have got some coverage. It took them nearly about 2 to 3 years before they were able to combine all this and become the national health insurance. So Malaysia, we are actually, instead of going towards having a harmonization in terms of different packages, we are breaking up the pool much more. This is not good for the national health financing situation, and it will lead to, my worry is that maybe 10 years down the line, are we going to become like US, where nearly about 30-40% of the population would not be covered, while the money is spent on private health insurance? It actually being controlled by a few private health insurance. They will actually be the main winner of this. They took a lot of profit, and they become the dictator for the whole health financing scheme. These are the wrong steps. Yeah, these are the wrong steps that the government is taking. We need to make sure that the government relook at this back and then reorganize themselves, and don't be actually reactive to some of the proposal by people who are against the national health insurance, saying that if the government launch the national insurance, they will lose the election. If they will lose the election, it is not because of the national insurance. There's many other issues. In fact, this is the right time for them to introduce this when the issues of healthcare costs in the private sector is actually escalating through the roof, and nothing is being done much effectively to control this. I think, to me, I still feel that we should give national health insurance a chance, looking at the long historical success in many countries, including most of the European countries. It started off in Germany. And I was quite surprised in one of the parliamentary question responded by the government is that, oh, we cannot do that because we are following the British model and not the Bismarck model. So we are talking about this kind of model. Why are we actually focusing on this? Nothing is cast in stones in terms of the policy. You should actually relook at this situation. Korea, for example, they follow the combination kind of model. Okay, both the Beveridge model and also the Bismarck model, where they run the national health insurance. So most of the countries in the world that are actually having very, what we say, more sort of policymakers that are more closer to the population. They are actually taking care of the population more than the industry, for example. I'm talking about the insurance agency. They will focus more and try to support national health insurance. That's my take on that, yeah.
Okay, thank you, Professor Dato. Your response highlights that equitable financing depends on the government's political will to ensure that people are protected and supported in their later years. So now, Professor Thompson, let us now consider what Malaysia can learn from international approaches, particularly in integrating oral health into the wider care of older adults. Like, based on your international experience in gerodontology and oral health research, what lessons can Malaysia consider as it prepares oral health care for an aging population?
Thank you for the question. I think the first thing to realize is that nobody has the answer. Nobody is doing it well. Everybody is grappling with the same issues in the dental systems in the various countries. I mean, we all look to Japan as sort of the demographic leader because their population has been aging at a faster rate demographically than anyone else in the world. And they have tried some things and done some good things, but they've also done some not so good things. And they certainly know what doesn't work. And I think there's been quite a lot of interesting work being done in Europe at the moment. And I think the advice for Malaysia would be quantify the problem, so collect the data, and not just epidemiological data on your older population. Conducting an oral epidemiological survey at national level is very expensive, and most ministries of health don't want to fund those anymore. Certainly our New Zealand one doesn't. We were lucky to do another national survey in 2009, and then what became only the world's second national oral health survey of oral health in the nursing home sector in 2012. And we learned a great deal from that. But realistically, we're never going to be able to get those resources again. But yeah, quantify the problem, collect the data, and as I said, not just epidemiological data, but health services data too. So those of you who are working in the treatment services, say special care, or in emergency dental services or clinics, collect the information. Who's presenting? What are they presenting with? Where are they from? What is the size of the problem, the scale of the problem, is whether it is a problem, poor oral health among older people. Frame the issues within your own oral healthcare system, of course, and the constraints in terms of the culture and the funding, the setup of your dental care system, and think constructively, but also think critically. And don't take at face value what other people tell you from other jurisdictions, including me. Work out the answers yourselves, informed by other people's experiences. And use a collaborative approach. The dental profession working on its own will fail. You see, somebody agrees with me there. Change will not occur quickly. Think about involving the aged care sector early and treat them as equals. The key group for the nursing home sector is the nursing staff. They are the gatekeepers. They control what happens. If you don't get them on side, good luck. Thinking about older people, they're not dental patients for any more usually than a couple of hours per year. The rest of the time they're out there, and the influences on their oral health lie way outside the control of the dental profession. Okay, so we've got to get realistic as a profession about how much we can actually change, and then thinking about the the nursing home sector, at any given time in New Zealand, for example, 5% of those aged 65 or older are in a nursing home. 5%, so 1 in 20. So you know that the proportion of the older population who will end up going through one of those places at the end of their life course journey is going to be at least 5%. Well, my colleague Joanna Broad in Auckland and her colleagues figured out using New Zealand data what proportion of older people actually do go through the system, and it's actually 50%. So half of us will end up going into a nursing home at some stage, at least for the last few months or years of our lives. I think part of what we've got to do is to support aging in place for as long as possible. So keeping older people in their own homes, supported to stay in their own homes and look after themselves for as long as they can, would be a good approach. We've got to support their day-to-day oral care. And if we're thinking now about the nursing homes, things like 5,000 part per million fluoride toothpaste. I know it's available in Malaysia, but I think it's available only via dentists or via prescription or something, as it is here. And we're trying to change that situation here, because the major problem in that sector is people's dentitions crumbling away through very high rates of tooth decay. And then a certain small proportion of them are inhaling bits of those teeth or bits of restoration or large bits of calculus, and then suffering from aspiration pneumonia, which is really is a threat to life. So we need to really focus on maintaining the integrity of their dentitions, and 5,000 parts per million fluoride toothpaste is an excellent start. We also need to tackle the high sugar culture in the nursing home sector. My colleague Jerry McKenna and his colleagues in Europe have, over the last few years, undertaken a cluster randomized control trial of various interventions in nursing homes, and they found that they worked to a certain extent, but the biggest hurdle was trying to change the fact that older people will have a cup of tea or coffee mid-morning with a sugary biscuit or piece of cake, which will then sit in the mouth and not go any further back for hours, and the dentition just disappears because of that exposure to the sugar. What else do we need to do? I think we need to be realistic. Don't think that we can treat or prevent frailty or dementia or any other condition through dental means, because it won't happen. You know. What else? I think to be realistic, change won't happen quickly. The major influences on older people's oral health lie outside our control in the dental profession. So we have to work collaboratively. And it's something that we haven't really been comfortable with over the years. We fought a long and hard battle to achieve our own professional status. And that seems to have made us reluctant to cede any ground in coming down off our lofty professional perch and actually talking to other professions and to people like nurses and carers to work out what exactly we can do to improve the lot of older people. So the lessons are challenging ones, and they're not easy, but the sooner you start, the sooner we might make some progress. But yeah, it's not going to be easy or quick. Thank you.
Okay, thank you, Professor Thompson. The international lessons that oral health should be integrated into general healthcare and long-term care with prevention again should continue throughout life, and particularly attention given to the institutional care. So now we'll now open we'll now open the discussion to questions from the audience. We have received several questions through the chat box. And Cik Azrul. Okay. So for a question from Kamarul Anwar Side 643, how can technology and telemedicine be leveraged to provide accessible, affordable, and high quality geriatric care? So I invite Mr. Azrul to respond to this question first.
Well, there's a lot of new tech and innovative devices, medical devices now that can be leveraged on for the use to provide aged care. And you can see this at some of the medical expos that you go to, and you'll see a lot of people showcasing, different devices. And I get excited also, when I consider things. We don't need to look at complex devices to address complex problems right off. We look at simple things. For example, like diabetics, people with diabetes, one of the things that they are in agony of very often is doing the daily prick of the finger to check your blood glucose level. And the problems is that when it comes to an older person, you feel really sad, like, you have to do that a couple of times a day maybe, and you're pricking a finger, and it feels like it's so much trouble and so much and you've got to do it regularly, right? So today there already are devices, for example, and I'm using this simply because I'm actually auditing one of these things myself, which is a CGM, a continuous glucose monitor, and you can actually fix it there. You can see here that you can fix to an individual, and it stays on for like 2 weeks, and is able to monitor and provide readings for blood glucose throughout the period of 2 weeks. For older person who is not needing to be daily pricked with a lancet and getting that drop of blood, I mean, it's a lifesaver. It changes the way you look at monitoring a person with diabetes, especially for geriatric care. Imagine if you can do it, it becomes more reliable. You can also make decisions concerning food intake, and also diet, nutrition, etc. But one of these devices may cost like 150 ringgit each time you buy them. So maybe in a month it costs 300 ringgit per month. So that could be prohibitive when you look at the way some of this tech or innovative devices are available, whether or not it's accessible for people. It's there. We have a lot of things that we can use today. Telemedicine can actually close the gap between individuals who need care from specialized services that are based in Kuala Lumpur, but you need a consult in, say, Kemaman. You can have telemedicine, but the problem right now is who's able to have access to those? Can they afford it? Do you need an internet connection? Can you use your phone, for example, to get the consult? And the good news is we've learned so much from COVID-19, the pandemic, in terms of actually leveraging on current technology, not even technology that is high-tech 10, 15 years away from market, but today, just using your smartphone, you can already use some of this benefit of technology to ensure that some of this geriatric care you're able to close. But we're still working and we're still learning. I think there's so much to learn from other countries, like I think what Prof. Ore was saying about how they have resolved some of their problems concerning this distance in terms of care. But technology definitely is one of the things that we can leverage to look for solutions. Over to you, Dr.
Okay, thank you, Mr. Azrul. Next, I'd like to invite Professor Dato to answer the same questions. How can technology and telemedicine be leveraged to provide accessible, affordable, and high-quality geriatric care?
Yes, this is again an interesting question. I think generally we agree that health technology, including telemedicine and also other new technology, will probably help to improve the quality of care that are being given and also accessibility. But as Azrul has mentioned, yeah, it is not that straightforward in terms of how we have heard about telemedicine for the last 10 years, but the mechanism of it being implemented has not been actually discussed properly. How these things are going to help improve our access to the services. Basically, when we talk about telemedicine, we need not only technology but also the human resource, people who are actually sending the information, and also those who are receiving the information at the receiving end. In our study earlier on, we found that there were issues where when cases are being referred from periphery to the central, the doctors, especially at the central level, maybe in KL or one of the teaching hospital, they are so busy with their own patients, and they may not have time actually to do that. So this is an important issue. It is not only the technology, but the system around it has to be put in practice. Other technology, including drugs, for example, new modalities of treatment, all this, if it is proven to be cost effective and proven to improve quality of care, they should be implemented. But then we must remember it is not always affordable by the country. Recently, in other health system, in other treatment, we were talking about robotic surgery. People are introducing robotic surgery in the country for treatment, like for example, some of the robotic operations, they use robots, for example, and also approach for the prostatectomy, for example. But then because the costs are so prohibitive, private insurance sends letters to all the hospitals that they are not going to cover if robotics management are being used for this patient, because the costs are very high. So because of that, because of the cost, not because of the quality. So that is one thing that we have to remember. When we have new technologies, we must make sure that these technologies are affordable and it is effective. But more importantly, it is cost effective. In other words, you will be able to produce services same quality or better quality at a much lower cost. I think that is a very important aspect that we need to consider. And all the new technologies nowadays in the government, they are being analyzed or being assessed by a group of people in a unit called health technology assessment. If it is approved by health technology assessment, then only the new technology can be considered to be implemented in the health system. But there's another step to that. They also carry out what we call the budget impact analysis. What would be the impact on the overall budget of the government, for example, if this new technology were to be included and were to replace the older approach in a particular treatment modalities. So there are more complicated kind of process that need to go through. Overall, the new technology that are cost effective and affordable should be implemented, but we need to build a strong system in order to adopt this. Yeah.
Okay, thank you, Professor Dato. Next, I'll invite Professor Thompson. A question from Dr. Cik Julia Jailan 8157. Can a life course approach to oral health, which starting in childhood, mitigate the rising cost of our aging society?
Well, that's a good question. Can you hear me?
Yes, we can hear you.
Yes. No, sorry, I thought I was muted. Yes, that's a very good question. I think ideally, yeah, but it would require a really long-term focus. And I don't know about your country, but my country, the politicians and policymakers tend to go from thinking about the next 3 years, because that's the length of our parliamentary term. So getting them to think any further ahead than the next 3 years is very difficult. But in terms of the principles, yes, I think. I mean, it's fashionable these days to knock the nanny state. You know, we've had the rise of the right around the world, and they've particularly after the pandemic, they seem to have captured the discourse, and now the state stepping in to improve people's lives is viewed as a bad thing by the, you know, certainly the people on social media, etc. But I think there's still a great opportunity there for the state to work benevolently in childhood to identify those children who are less capable and are going to have poorer lives, and to think about how it can support them to have better lives through life. And again, it gets political because, you know, you talk to anybody from across the political spectrum and they'll all agree that child inequalities, social inequalities in child health and child achievement, etc., are a bad thing. So then when you come to the next point, which is, okay, we need to improve those children's lives. How are we going to do that? Well, let's support their parents. Suddenly the left-right split comes in because the right doesn't want to have anything to do with giving what it considers to be resources to the feckless poor who are only going to waste it, you know, whereas those of us on the left side of the whole thought process were thinking, well, it's a no-brainer. You know, you cannot eradicate or reduce child poverty and child inequalities and help people to have better lives unless you actually start with the household, you know. Yeah, as a principle, as an idea, I really like the idea. In terms of getting it into anything practical in the long term, I'm rather more cynical about that because I don't have much faith in my fellow humans, particularly recently, you know. But there are a lot of good people in health and in social policy and in academia, and I think it's our duty to keep witnessing, to keep advocating for these things, and to do as much as we can to try and change the system, even though it can at times seem like a thankless task.
Okay.
Yeah.
Okay. Next, we have a question from Faiz Hanim. If Malaysia had to prioritize one major investment for an aging society with the current budget, what should come first and what would need to be deprioritized to make it possible? So I invite Professor Datuk to respond to this question.
Yeah, okay. Thanks for asking this question, but I think this is again quite difficult for us to pinpoint one major kind of approach. You know? We must remember that managing the aged society, for example, needs a multi-sectoral approach. Ministry of Health alone cannot actually do it. You need to actually work together with other ministries. You need to have enough budget and all that. Having said that, we go back to the public health perspective of managing any health system in the world. I think the first and foremost, we should actually put a lot more investment on preventive services, because it will benefit both the aged and also every individuals in the population, while they will grow up and become an aged person in the future. At the moment, our preventive services in Malaysia, especially we are talking about immunization, screening, and also early intervention, has not been well coordinated. We probably spend less than 25% of our overall budget on preventive services. So if you go back to the health white paper, there was suggestion that we should increase to at least 50% of the MOH expenditure to focus on preventive services. So if we do that, then it will actually benefit both the older people as well as the people who have not reached that age yet. So screening for chronic diseases, for example, should be started as early as possible, and should be actually organized in a way that everybody will have easy access for that. I think I would put more emphasis on that. In terms of this investment, we should actually reduce the focus on curative care. In fact, if we spend a lot more on preventive, then the amount of resources required for curative care could be gradually decreased. At the moment, nearly about 65 to 70% of our resources goes into curative care. I think there's a big imbalance in terms of the resource use. And we must remember that in terms of return of investment, it is much higher returns will be able to be obtained if we were to go towards the preventive services. I think screening for cardiovascular condition, for example, screening for heart disease, early screening for diseases, especially cancers, for example, would be beneficial, and it will help to reduce the likelihood of our aged or older population to suffer from diseases in the future, because we were able to take early intervention. I think that is my response to that. Yeah.
Okay, next from Assistant Professor Dr. Khaja Amjad Hussein. His question is, should oral health assessment become a routine part of geriatric medical examination? So for this question, I would like to ask Professor Thompson to respond to this.
Yes, absolutely. Yeah, because, I mean, if you're doing a geriatric health assessment of someone, and, you know, I mean, the medical profession, I don't want to be rude about them, but they tend to view the mouth as an aperture, an access point to either the pharynx, the lungs, or the esophagus. And it's time they stopped on the way through and had a look around before they got to the nasopharynx or the oropharynx, or the pharynx, I should say. But yeah, it should be a routine part. And it's not about saying to geriatricians or to doctors, you've got to learn how to examine teeth or to examine periodontal tissues or whatever. It's about asking the questions, asking people about their oral health and whether they can chew the foods they want to, whether they can talk properly, etc. So it's about their comfort. So again, taking a functional approach, and then and asking them whether they have dry mouth. And if the answers to any of those indicate that there is a problem, then there should be a trigger where a detailed oral health assessment is undertaken, whether it's by a dentist or an oral health therapist, it doesn't matter, or a hygienist, somebody who knows, how to interpret what they see when they look in the mouth. So yes, an oral health assessment should become a routine part of the geriatric medical assessment, as long, alongside, all the other information that's collected, because otherwise you don't have a complete picture of the person's status and how their health is. So I'm a great supporter of that sort of assessment, and there are tools out there that can be used, such as the oral health, the OHAT, and others. Yeah, so they are out there. Thanks for that question. Good one.
Okay, next, there's a question from Kamarul. From Kamarul Anwar Siddiq, 643. What role should artificial intelligence and predictive analytics play in preempting health crises in the elderly before they require costly emergency interventions? I believe that both panels can answer this question, but I would like to invite Professor Maria Thompson to respond to this first.
Yeah, thanks. Hopefully a minor role, if any. I'm not really a great fan of the AI hype, and I don't think that AI can replace human judgment. So I'm not a fan, basically. As an editor, I see a lot of AI generated stuff, and it's pretty ordinary. And of course, it's going to improve, but at what cost to our society and to the environment, etc., etc. So I would discourage anyone thinking to use AI in this sort of way. I think particularly for making judgments, complex judgments about complex situations in older people, you need the informed human touch. Yeah. So that's where I stand on this anyway.
Okay, thank you, Professor
Syed
Thompson.
might have a different approach.
Yeah. Okay, thank you, Professor Thompson. And then I would like to invite Professor Datuk to add on for this question.
I think I tend to agree with Prof. Maurice Thompson's suggestions and views. I think AI is still very new, and most of the time AI depends on whatever is available in the internet. They try to search, and then they try to predict based on whatever that they have on the internet, and it's bound to make a lot of mistake if you are not careful about that. So it can be used for example, theoretical work, and if you want to look at literature reviews and all that, you can do that, but don't depend. We should not depend on that to manage patients. I think there are still a long way to go. In fact, AI provider themselves, they are trying to train the system in order to learn more and more. I think we should not use that for management of patients, and we should actually concentrate on using our real intelligence rather than artificial intelligence. Yeah, thanks. Yeah.
Okay, thank you, Professor Dato. Okay, next, this question from... Okay, as Malaysia prepares for an aging society, could dental therapies play a greater role in community-based prevention, oral health screening, and domiciliary care for older adults? So I'd like to invite Professor Thompson to respond to this question.
Absolutely. Here in New Zealand, we now have oral health therapists who are trained in both hygiene and dental therapy, and we've done recently, over the last few years, we've done an interventional trial trialing their deployment. We involved 2 large nursing homes near Wellington, and we deployed an oral health therapist in each one, and their task was to work with the staff, to empower the staff, to upskill the staff, and also to provide one-on-one advice to the residents. And interestingly, when we compared the before and after clinical measures like how much plaque was there and et cetera, there wasn't much of an effect. But where there was an effect was in terms of the knowledge of the staff and their confidence in looking after the residents, and in the residents themselves, they felt more empowered as well. And we're currently we've just recently published the actually are they no it's coming later this year. We have a special issue on interventional oral health research in gerodontology, and our paper from that will be in there. That's on the clinical findings, but we're currently working on a paper on the qualitative findings, which is actually more interesting and more useful, I think. So yes, and one of the reasons for my big yes on this issue is that dentists don't really want to go there. You know, we surveyed New Zealand dentists a few years ago, and about a quarter of them had to go and visit a nursing home in their community, but only about half of that proportion were prepared to go back, and even fewer were prepared to actually undertake a regular sort of role in that sort of sector. So they're just too busy. Dentists are comfortable working in their own clinics with their own toys, you know, with the patients coming to them, and to go out and deliver domiciliary care in what is a highly variable workplace situation ergonomically for operative dentists. Nobody really wants to, certainly in the dental profession, wants to do it. But the oral health therapists who have been for years, decades, you know, under the thumb of the dentists, they're dead keen to do it. They're dead keen to get into that sector. So my point on this is my take on it is to say to them, you go for it. You know, you've got an open field there, so you get the training, develop the skills, and get in there and make a difference. You know, I think that should apply to Malaysia too. Yeah, that's my answer. I hope that is informative.
Okay, next, Professor Thompson, how can NGOs and trained community volunteers support preventive and oral health care for older adults? Could you share an example that Malaysia could learn from?
It's an interesting one. I don't have much or any experience really of this. I think as a principle, it's fine. The problem with the NGOs is, particularly if they're charities, they tend to have fairly limited coverage. And I don't think a model based on charity is necessarily sustainable in the longer term. But certainly for particular areas of the community, such as in New Zealand, our Maori population, we've had the Maori-led, a great advance in Maori-led, funded and delivered health services for their people. And there's some really interesting stuff being done by them using people from their own community. So the trained community volunteers can actually, you know, they have been making a difference, but I don't think we have systematically evaluated it yet. But it's certainly something that needs to be looked at. Yeah, it's an interesting area. I haven't really answered the question. I've dodged it. Guilty.
So we have our last question. Okay. From Kamarul Anwar Sidik 643, how can we adapt Japan's technological and insurance frameworks to suit our own nation's economic realities? So actually, I would like to invite all three panels to answer this. So first, I'd like to invite Mr. Azrul to respond to this question first.
Can I defer to Prof. Syed first, because he's the doyen of insurance, so maybe he goes first.
Yeah.
I'll come in.
Yeah,
second,
sure.
yeah.
Yeah.
Must defer to the master. Yeah.
Okay, so I'd like to invite Professor Dato to respond to this question first. Okay.
Well, I visited Japan for the first time in the 90s when I was learning about health insurance. I think Japan is one of the countries that we visited under the scheme. We saw how they manage their aged population very well. And Japan is quite unique compared to Malaysia because they spend quite a lot on their healthcare resources. They started the national health insurance long time ago, and they even have the long-term care, which was actually rolled out a bit later than the national health insurance. But one thing that I found that very interesting in Japan is that they have what we call a time bank, where people who contribute voluntarily to the aged population, later on they can claim back the services that they have provided will be provided by other people. It was quite a unique thing. I think Japan is a good country for us to emulate. Their politicians are quite well versed about the needs of the country. The agent in the country is very powerful in terms of influencing the government policy. While Malaysia is still struggling with what we call political unfeasible to implement national insurance, other countries that Japan have moved forward, leaving many of the countries out of the system. And I think we have a lot to learn from Japan, and I really hope that we would be able to follow at least some of the good things that they have done. Of course, Japan is not a signatory to the FCTC. I think that is the thing that we should not follow. They allow people to smoke everywhere, and then they tend to use a lot of technology, which sometimes it is too much technology. Also, it is not too good for the population because it leads to increase the healthcare costs. Overall, I think the long-term insurance in Japan is a good thing that we can start, but it is actually on to top up what we call the national health insurance. It is not stands on its own, so we cannot run insurance only for the poor if we do not have a good national insurance as a backup. I think that's my response to that. Yeah. Over to you, Azrul. What's your view on?
Thanks, Prof. Said. I knew it was right to let you to lead off first because I totally in agreement with you as well. And I also wanted to mention that when we look at some of these other jurisdictions, they are high income societies, which for Malaysia, we are currently at upper middle income and about to become high, but we still don't feel that way, and we certainly don't see the kind of revenue or earnings that we see per household at the level that we would see in countries like in South Korea, Taiwan, Singapore, and Japan, and even I would argue in Australia, New Zealand. It's a different level of affordability and ability to contribute into this pool that we need to finance and to sustain an aged care infrastructure. This is very important for us to understand because we can't just, of course, just copy and paste these remedies and put them into the Malaysian context because it has to fit with what we have, right? So one of the things that we need to do better, I think, is communicate this issue and the urgency better to get the kind of support that we need to ensure that people make the decisions in the understanding that the insurance framework is needed to protect us when we are at that point of time in our life. And the concept of solidarity is critical, meaning we need to understand that what we contribute may not benefit us immediately today, but it helps with someone else who already is on that journey, who is at that point of stage in their life to be able to get the care that they need. And we invest in our own care for the future with at least like 20 years of contributions. And I point that out because in some of these countries that we mentioned, they start contributing at the age of 40. And the idea is that you contribute for at least 20 years so that the contribution then helps fund you once you decide to retire at age maybe 65 or something like that. And that is what pays for that care later on. It's not an airy-fairy hope somebody will pay for mechanism, which is what we tend to have today. But it is you yourself investing in that. We need that to be understood not in terms of just us paying for ourselves, but also paying for others as well. Solidarity is key here for us to make sure that even a national health and social insurance framework that we introduce gets supported and adopted. Because today, if we did that, well, we've seen what happened to Lindung 24 and the U-turn that has happened. It's because people see there's no benefit to it, towards it, and they don't see how they can see where their money is going to returns of value that needs to be understood and communicated properly. So I would definitely want to see those other countries that are facing the aging question in real time today and learn from them on how they are responding, what the needs are, most importantly, how to pay for it, but also recognize the reality of the situation, that it is not just urgent, it's now, but it's also costly. Somebody has to pay for it, and we need to be able to recognize the investment needs to be made, not just in terms of the helping today's older population today, but also the future ones as well. I think we are not there yet, but we are slowly trying to communicate and trying to get that point across. But I think in terms of society, we have a lot of work to do when it comes down to it. We can't simply just take from other countries and plonk it into our own situation, because we have realities that we need to also address, but also we need to recognize the urgency. If not, we're going to leave people behind. Over to you, Dr. Noha.
Okay, thank you, Mr. Azrul. And next, I'd like to invite Professor Thompson to respond to this question. So,
thank you. I've just recently spent 4 weeks in Japan. I had the Japanese Society of Gerodontology meeting in Osaka, and it was great. I really enjoyed it, and I can report that Japan is almost as good a place to eat as Malaysia. So, yeah, it was good.
Sacrilege there, Prof. Sacrilege there.
Yeah. I thought that might be controversial, you know. What's really interesting from a dentist's point of view, looking at the Japanese system, and particularly for the care for older people, is that routine dental care for older people is indeed covered by the Japanese system, by the social security payment sort of system somehow. But the Japanese Dental Association was very cunning in that it managed to get something called oral hypofunction, also known as oral frailty, included in the fee schedule, the dental fee schedule for treating older people. And it's basically a series of oral exercises aimed at strengthening the tongue and the circumoral musculature and the muscles of mastication, on the assumption that it can help offset general frailty. This is a big assumption, and there's no evidence for it. But nonetheless, they on the basis of some research that they'd done showing associations between the two, they managed to get the government to start paying for treatment for this particular condition, which I thought is very cunning of them, but I'm not sure. Being editor of gerodontology, I see the research coming in on this, and I get to evaluate it and get to send it out to review, and I see the reviews, and the supporting evidence for this hasn't yet emerged, but despite that, it's in the payment schedule for better or for worse. And I think we can all learn something from how cunningly the Japanese dentists, organized Japanese dentistry, managed to get that into the payment system. So I think it just goes to show that anything is possible as long as you know who to influence, I suppose. And there's a lesson for us there, that a lot of the decisions that are made on health and insurance and the use of technology, etc., policy decisions, the data, having good data is only part of the decision. It's also about politicians' prejudices or assumptions and what might be expedient for them at the time. So there's a degree of luck involved as well in how we can change the system to improve things for older people. But I see that as a good lesson for us all anyway. Thank you. Good question.
Okay, thank you for the thoughtful questions from the audience, and I thank also the panels for their valuable responses. To close our panel discussion, I'd like to each panelist to identify one clear priority. Based on your expertise, what is the single most important and national priority Malaysia should address now to prepare for an aged nation by 2048? Maybe Professor Datuk can start us off first.
Yeah. Thanks for asking this question. I think to me, I'm still biased towards the establishment of a proper health financing scheme. I think that if I'm in power, the first thing that I would do is to set up a team to establish the National Health Insurance Program. We almost near that, but it was decided not to proceed after the health white paper changed hands from the previous government to this new government. I think a lot of issues can be settled, not all, but at least it will help not only the aged population, but the overall health system that we are seeing in the process of collapsing today because of the lack of resources, lack of coordination, and also poor integration between the various sectors within the health system. I will give that as a high priority if you want to solve this population of access to services by the older people in the country. Okay.
Okay, next I invite Mr. Azrul.
You are muted, I think.
Okay, so next I'll invite Mr. Azrul to address
you are muted.
Sorry. Okay.
Azrul, yeah, you are muted.
Oh, Azrul, Mr. Azrul, you are muted. Mr. Azrul, sorry, but you are muted.
We cannot hear you.
Okay. Again, sorry, Mr. Azrul. Can you repeat again?
We lost you last 5 minutes. Yeah.
Can't hear.
Apa ni? Okay. Sorry, Mr. Azrul. Can you try to repeat again? Because we cannot hear you. Okay.
Yes.
Okay. Okay. So tak dengar. Okay, sorry, Mr. Azrul, maybe there's some technical problems okay, so first I'll invite Professor Thompson to respond to this question. What is the single most important national priority Malaysia should address now to prepare for an aged nation by 2048? Later we'll return to Mr. Azrul.
Right. Well, from an epidemiological perspective, stroke, dental epi, stroke, public health perspective, I've got two things. One is eradicate smoking. The second is to reduce the consumption of high sugar, high fat, high salt foods. Basically, something that is known as the neoliberal diet. It's the industrial cheap diet that the world, certainly the developed world, we all feed the poorest in our society, and that just contributes to so much of the disease burden out there and shortens lives and also compromises dentitions. So taking a real public health approach, what can we do to improve what people eat out there? And that will in turn, along with eradication of smoking, which we were well on target to do here in New Zealand until we had a change of government 3 years ago, but I won't go into that. That would do much more to improve the population's health as it goes through the life course than anything else, I think. Yeah. That's all I have.
Okay. Next, I invite Mr. Azrul to address what is the single most important national priority Malaysia should address now to prepare for an aged nation by 2048. Cik Azrul, Mr. Azrul. Mr. Azrul, are you ready? Okay. Okay. So as we come to the end of this meaningful webinar on National Imperative Aged Nation by 2048, why a healthy aging society is a national health and economic priority, I'd like to express my sincere appreciation to our distinguished panelists for their valuable insights, thoughtful reflections, and generous sharing of expertise. Our deepest thanks go to Professor Emeritus Dr. Syed Muhammad Al-Junaid bin Syed Junaid, Mr. Azrul Muhammad Khalid, and Emeritus Professor Murray Thompson for guiding us through this important discussion. Today's session has helped us view healthy aging from several important perspectives, including health economics, public health policy, oral health, life course prevention, resource allocation, public understanding, and national preparedness. From today's discussion, one key message is clear. Healthy aging is not only about living longer, it is about living with dignity, independence, function, participation, and quality of life. As Malaysia moves towards becoming an aged nation by 2048, preparation cannot be delayed. It must begin now, through early action, strong systems, and shared responsibility across government, healthcare providers, families, communities, and individuals. We have also been reminded that aging should not be seen only as a challenge or a cost, but also as an opportunity. With the right planning, investment, and support, Malaysia can empower older adults to remain healthier, more independent, and able to continue contributing meaningfully to their families, communities, society, and the economy. This message aligns strongly with the theme of SMILE 5.0, Empowered Older Adults Inspiring Generations. Older adults should not be viewed only as recipients of care, but as individuals with experience, wisdom, and continuing roles in society. At the same time, empowerment must be supported by accessible healthcare services, strong oral healthcare systems, trained professionals, inclusive policies, and preventive care across the life course. To all participants, thank you for your attention, questions, and active engagement throughout this session. We hope that the knowledge shared today will inspire continued discussion, better planning, and practical action towards a healthier, more inclusive, and better prepared aging society for Malaysia. Please stay tuned for our upcoming SMILE 5.0 sessions, which will continue at the same time and on the same platform. Thank you once again for your participation, and we look forward to seeing you in the next session. With that, I now hand the session back to our MC to continue the program. With that, we conclude today's webinar. Thank you, goodbye, and Assalamualaikum warahmatullahi wabarakatuh.
Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Noha. With that, we have come to the end of our first webinar of the SMILE 5.0. Please remain with us as we proceed to the Smile 5.0 webinar launching ceremony. Before that, participants are kindly reminded to complete the participant satisfaction survey via the link provided in the YouTube live chat after the ceremony. An e-certificate of the participation will be issued upon the completion of the survey. We also welcoming you to our second webinar tomorrow at the same time and via the same streaming platform. Thank you once again for being with us today. Wabillahi taufiq wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh.
Assalamualaikum.
Salam.
Hi everyone, join us for webinar 2, the policy roadmap, crafting the national policy roadmap for healthy aging. Wondering why this topic matters? Let's hear from our head of department, Dr. Nawar.
Assalamualaikum and hello everyone. So why webinar 2 is important? Malaysia is becoming an aging nation and it's going to impact everything from our economy, housing to healthcare and even our own family dynamics. So I highly encourage you to join this webinar featuring panel of experts where they will explore policy gaps, the silver and care economy and the actions we need to take so our seniors can age independently with a better quality of life. So don't miss out and see you there.
Hi everyone, I'm your moderator for the upcoming webinar 2 and I'm not alone. I'm going to bring you an expert to talk about this. First, we have Puan Elena Mukris from Kazanah Research Institute, we have Mr. Chai Sentin from My Aging, and we have Dr. Mustafa Jaafar, Deputy Director of Health for the Oral Health Division. Please subscribe to our YouTube channel, Smile UiTM 450, and wait for our live session. Stay tuned.
Ceria berseri 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni Smile 5.0 membawa inspirasi. Membawa inspirasi. Selalu ceria berseri 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni Smile 5.0 membawa inspirasi. Senyumlah selalu ceria berseri 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni Smile 5.0 membawa inspirasi. Senyumlah selalu ceria berseri 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni Smile 5.0 membawa inspirasi. Membawa inspirasi. selalu ceria berseri, 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni, Smile 5,0 membawa inspirasi. Senyumlah selalu ceria berseri, 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni, Smile 5,0 membawa inspirasi. Senyumlah selalu ceria berseri, 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni, Smile 5,0 membawa inspirasi. Membawa inspirasi. Senyumlah selalu ceria berseri, 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni, Smile 5,0 membawa inspirasi. Senyumlah selalu ceria berseri, 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni, Smile 5,0 membawa inspirasi. Senyumlah selalu ceria berseri, 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni, Smile 5,0 membawa inspirasi. Membawa inspirasi. Senyumlah selalu ceria berseri, 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni, Smile 5,0 membawa inspirasi. Senyumlah selalu ceria berseri, 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni, Smile 5,0 membawa inspirasi. Senyumlah selalu ceria berseri, 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni, Smile 5,0 membawa inspirasi. Membawa inspirasi. Senyumlah selalu ceria berseri, 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni, Smile 5,0 membawa inspirasi. Senyumlah selalu ceria berseri, 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni, Smile ceria berseri 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni Smile 5.0 membawa inspirasi. Membawa inspirasi. Senyumlah selalu, ceria berseri 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni Smile 5.0 membawa inspirasi. Senyumlah selalu, ceria berseri 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni Smile 5.0 membawa inspirasi. Senyumlah selalu, ceria berseri 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni Smile 5.0 membawa inspirasi. Membawa
smiles. We're building a community of healthy smiles. Knowledge and care walking hand in hand, spreading the joy across the land. So keep that smile bright and free. 20 at 64, you and me. Generations together, shining so bright. Smile 5.0, bringing the light.
masyarakat bersama harmoni. I untuk ideal, impian di hati, L untuk lancar, senyum setiap hari. I untuk ikuti, kasih diberi. Senyumlah selalu, ceria berseri. 20 gigi di usia 60 tentu nanti.
Senyumlah selalu, ceria berseri. 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni. Smile 5,0 membawa inspirasi.
Indahnya songket di atas para, berbenang emas cantik jalinan. Madah diungkap awal bicara, lafaz bismillah kita mulakan. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera. Yang berhormat, Datuk Hajah Hanifah Hajar Taib, Timbalan Menteri Kesihatan Malaysia. Yang berusaha, Profesor Madya Dr. Masurialis Ahmad, Dekan Fakulti Pergigian UiTM. Yang berusaha, Profesor Dr. Budi Aslini Mat Sabri, Pengarah Program Doktor Kesihatan Pergigian Awam Fakulti Pergigian UiTM. Yang berusaha, Dr. Nur Amalina Hani Senin, Pengarah Program Smart 5.0. Barisan pengurusan universiti dan fakulti, para panel dan moderator siri webinar dan podcast program Smart 5.0, warga akademik, para profesional kesihatan, para peserta serta hadirin yang saya hormati sekalian. Alhamdulillah, marilah kita bersama-sama memanjatkan kesyukuran kehadrat Allah Subhanahu Wa Taala kerana dengan limpah izin dan kurnianya kita dapat bersama-sama dalam majlis perasmian siri webinar dan podcast program Smart 5.0 anjuran Fakulti Pergigian Universiti Teknologi Mara pada tahun 2026. Saya, Dr. Muhammad Firdaus Mokhtar, pelajar Pasca Siswazah Program Doktor Kesihatan Pergigian Awam Fakulti Pergigian UiTM akan mengacarakan majlis perasmian siri webinar dan podcast Smart 5.0. Saya amat mengalu-alukan kehadiran penonton semua ke majlis yang diadakan secara atas talian ini. Para penonton yang dihormati sekalian, program Smart 5.0 tahun 2026 merupakan kesinambungan daripada program Smart yang telah bermula sejak tahun 2021 lagi. Selain dari memenuhi keperluan akademik program Doktor Kesihatan Pergigian Awam Fakulti Pergigian UiTM, program ini bertujuan untuk mendekatkan masyarakat dengan isu-isu kesihatan pergigian awam penting di samping menyampaikan pendidikan kesihatan pergigian kepada masyarakat. Para penonton yang dihormati sekalian, majlis kita pada hari ini akan dimulakan dengan nyanyian lagu Negaraku dan diikuti dengan lagu Wawasan Setia Warga UiTM.
Bersatu kita warga UiTM, kita bangsa perkasa, taat dan setia untuk negara, penuh semangat wajar. Kita jangan mudah terlupa pengorbanan perjuangan anak bangsa. Kita jangan mudah terleka kemajuan keamanan yang ada. Kita berterima kasih pada pemimpin-pemimpin negara. Kita rasa penuh bersyukur kerahmatan kemuliaan darinya. Kamilah pendukung pewaris bangsa, kamilah penalar bangsa Malaysia, kamilah warga berwawasan,
Salam disua pembuka madah disulam dengan alunan tingkah. Doa dibawa ke majlis indah, disulam kalimah penuh barokah. Bagi memberkati majlis kita pada hari ini, dengan ini saya ingin menjemput dan mempersilakan Dr. Muhammad Huzaifah Jusoh untuk memimpin bacaan doa.
Bismillahirrahmanirrahim. Alhamdulillahirabbil alamin. Wassalatu wassalamu ala asyrafil anbiya'i wal mursalin wa ala alihi wa sahbihi ajma'in. Ya Allah, Ya Rahman, Ya Rahim. Kami merafakkan rasa kesyukuran yang tidak terhingga atas limpah rahmat-Mu. Kerana dengan izin-Mu dapat kami berhimpun secara maya pada hari ini bagi menjayakan majlis perasmian siri webinar Smile 5.0. Kami memohon agar Engkau memberkati majlis ini, menaungi perhimpunan kami dengan rahmat dan menjadikan setiap ilmu yang dikongsikan sebagai amal jariah yang berkepanjangan. Ya Allah, Ya Azim, Ya Hakim, sesuai dengan matlamat siri webinar ini, kami memohon agar Engkau jadikan platform ini sebagai medan penyebaran ilmu yang bermanfaat dalam usaha memperkasakan agenda penuaan sihat, kesihatan pergigian serta kesejahteraan holistik warga emas dan komuniti kami. Kurniakanlah kefahaman yang mendalam kepada seluruh barisan panel, moderator dan para peserta yang mengikuti siri webinar ini. Ya Muhaimin, Ya Latif, kami juga memohon perlindungan darimu sepanjang webinar ini berlangsung. Peliharalah urusan kami daripada sebarang gangguan teknikal atau kesulitan lain agar penyampaian ilmu dapat berjalan dengan lancar, jelas dan sempurna dari awal hingga ke akhirnya. Ya Allah, Ya Zal Jalali wal Ikram, berkatilah usaha murni barisan pimpinan, pensyarah, para pelajar pasca siswazah kesihatan pergigian awam serta seluruh warga Fakulti Pergigian UiTM yang telah bertungkus lumus merealisasikan program Smile 5.0 ini. Jadikanlah inisiatif ini sebagai pemancu impak positif dalam membina masyarakat yang prihatin, inklusif dan sejahtera. Rabbana atina fid dunya hasanah wa fil akhirati hasanah wa qina azaban nar. Wa sallallahu ala sayyidina Muhammad wa ala alihi wa sahbihi wa sallim. Walhamdulillahi Rabbil Alamin.
Amin Ya Rabbal Alamin. Terima kasih diucapkan di atas bacaan doa yang telah disampaikan sebentar tadi. Seterusnya dijemput yang berusaha, Dr. Nur Amalina Hani Senin, pengarah program Smile 5.0 bagi menyampaikan ucapan. Majlis dengan ini mempersilakan.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera dan salam UiTM di hatiku. Terima kasih Tuan Pengerusi Majlis. Yang berhormat Datuk Haji Hanifah Hajar Taib, Timbalan Menteri Kesihatan Malaysia, yang berusaha Profesor Madya Dr. Masurialis Ahmad, Dekan Fakulti Pergigian Universiti Teknologi Mara, Sungai Buloh, yang berusaha Profesor Dr. Budi Aslini Mat Sabri, Pengarah Program dan Penyelaras Kursus Program Dr. Kesihatan Pergigian Awam, barisan panel jemputan, moderator, para peserta serta hadirin yang dihormati sekalian. Alhamdulillah, syukur kehadirat Allah SWT kerana dengan limpah rahmat dan izinnya, kita dapat bersama-sama dengan Majlis Perasmian siri webinar dan podcast Smile 5.0 pada hari ini. Bagi pihak seluruh jawatan kuasa penganjur, saya mengucapkan setinggi-tinggi penghargaan kepada Yang Berhormat Datuk, para tetamu kehormat, panel jemputan, moderator serta semua peserta yang sudi meluangkan masa untuk bersama-sama menjayakan siri ini. Kehadiran semua amat bermakna dan menjadi satu penghormatan buat kami. Hadirin yang dihormati sekalian, Smile bukan sekadar nama kepada program ini, malah merupakan satu nilai yang menjadi pegangan kami sepanjang penganjurannya. Smile membawa maksud selamat, masyarakat, ideal, lancar dan equity. 5 nilai ini menjadi asas kepada setiap penilaian dan pelaksanaan program kami. Sejak diperkenalkan 5 tahun yang lalu, Smile telah mengangkat pelbagai tema yang mencerminkan keperluan kesihatan semasa negara, Bagi tahun ini, kami memilih tema Warga Emas Perkasa Inspirasi Generasi atau Empowered Older Adult Inspiring Generation sebagai usaha menyokong kesedaran masyarakat terhadap kepentingan penuaan yang sihat dan berkualiti. Akhir kata, kami berharap agar siri webinar dan podcast Smile 5.0 akan menjadi platform yang memberi manfaat kepada semua peserta, memperkukuhkan jaringan kerjasama serta menyemarakkan usaha bersama dalam memperkasakan agenda penuaan sihat di Malaysia. Sekian, terima kasih.
Terima kasih diucapkan kepada Yang Berusaha Dr. Nur Amalina Hani Senin atas ucapan sebentar tadi. Majlis diteruskan dengan menjemput Yang Berusaha Profesor Dr. Budi Aslini Mat Sabri, Pengarah Program Doktor Kesihatan Pergigian Awam Fakulti Pergigian UiTM bagi menyampaikan ucapan. Majlis dengan ini mempersilakan.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh dan salam sejahtera. Terima kasih pengerusi majlis. Yang berhormat Datuk Hajah Hanifah Hajar Taib, Timbalan Menteri Kesihatan Malaysia. Yang berusaha Profesor Madya Dr. Mas Suryalis Ahmad, Dekan Fakulti Pergigian Universiti Teknologi Mara Sungai Buloh. Yang berusaha Dr. Nur Amalina Hani Senin, Pengarah Program Smile 5.0, panel-panel jemputan, moderator, warga akademik, para peserta serta hadirin yang saya hormati sekalian. Alhamdulillah, bersyukur kerana kita dapat berhimpun dalam majlis perasmian Smile 5.0 siri webinar dan podcast pada hari ini. Terlebih dahulu, saya ingin mengalu-alukan kehadiran yang berhormat Datuk, para panel jemputan, moderator serta semua hadirin yang sudi meluangkan masa bersama-sama dalam menjayakan program ini. Hadirin yang dihormati sekalian, program Doktor Kesihatan Pergigian Awam diwujudkan dengan aspirasi untuk melahirkan profesional yang bukan sahaja mempunyai kepakaran dalam bidang pergigian, malah berupaya memimpin perubahan melalui penyelidikan, kolaborasi serta penglibatan aktif bersama masyarakat. Selaras dengan aspirasi tersebut, program SMILE diwujudkan sebagai platform pembelajaran transformatif berasaskan pengalaman yang memberi peluang kepada pelajar mengaplikasikan pengetahuan, kemahiran dan nilai kepimpinan melalui penglibatan secara langsung bersama komuniti serta pelbagai rakan strategik. Sepanjang 5 edisi penganjurannya, SMILE sentiasa berkembang mengikut keperluan dan cabaran kesihatan semasa negara. Bermula dengan kempen kesedaran perkhidmatan pergigian norma baru ketika pandemik COVID-19, diikuti tema Mental Health for Dental Wealth, kesihatan mulut untuk semua dan Kick the Habit, Drop the Vape, Live More. Setiap edisi mencerminkan komitmen program Doktor Kesihatan Pergigian Awam UiTM untuk memastikan pembelajaran pelajar sentiasa responsif terhadap keperluan dan cabaran kesihatan semasa negara. Bagi SMILE 5.0, pelajar mengangkat tema Warga Emas Perkasa Inspirasi Generasi sebagai respons kepada perubahan demografi negara yang dijangka mencapai status negara tua menjelang tahun 2030. Tema ini mencerminkan keperluan untuk menyediakan bakal profesional kesihatan yang memahami cabaran masyarakat menua serta mampu menyumbang kepada penyelesaian yang lebih menyeluruh. Pendekatan SMILE 5.0 turut diperluaskan melalui program komuniti, lawatan domisiliari, kini dengan siri webinar dan podcast bagi memberi pendedahan kepada pelajar terhadap kepentingan kolaborasi merentas disiplin, perkongsian ilmu serta penglibatan pelbagai pihak dalam menangani isu kesihatan awam. Akhir kata, saya berharap pengalaman menganjurkan SMILE 5.0 ini bukan sahaja memberi manfaat kepada peserta, malah menjadi pengalaman pembelajaran transformatif yang bermakna kepada para pelajar dalam membentuk mereka sebagai pemimpin masa hadapan dalam bidang kesihatan pergigian awam. Sekian, terima kasih.
Terima kasih diucapkan kepada Yang Berusaha Profesor Dr. Budi Aslini Mat Sabri atas ucapan sebentar tadi. Majlis diteruskan dengan menjemput Yang Berusaha Profesor Madya Dr. Mas Suryalis Ahmad, Dekan Fakulti Pergigian UiTM bagi menyampaikan ucapan. Majlis dengan ini mempersilakan.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera dan salam UiTM di hatiku. Terima kasih saudari pengacara majlis. Yang berhormat Datuk Hajah Hanifah Hajar Taib, Timbalan Menteri Kesihatan Malaysia. Yang berusaha Profesor Dr. Budi Aslini Mat Sabri, pengarah program Doktor Kesihatan Pergigian Awam. Yang berusaha Dr. Nur Amalina Hani Senin, pengarah program SMILE 5.0. Barisan panel jemputan dan moderator, warga akademik, para peserta serta hadirin yang saya hormati sekalian. Alhamdulillah, marilah kita bersama-sama memanjatkan kesyukuran kehadrat Allah Subhanahu Wa Taala kerana dengan limpah izin dan kurnianya, kita dapat bersama-sama dalam majlis perasmian siri webinar dan podcast SMILE 5.0. Terlebih dahulu, saya ingin merakamkan setinggi-tinggi tahniah dan penghargaan kepada para pelajar tahun 1 program Doktor Kesihatan Pergigian Awam serta seluruh jawatan kuasa penganjur atas usaha dan komitmen dalam menjayakan siri webinar dan podcast SMILE 5.0. Saya percaya bahawa penganjuran program berskala sebegini bukan sahaja mencerminkan keupayaan pelajar dari segi akademik, malah turut membentuk kemahiran kepimpinan, komunikasi, pengurusan dan kerja berpasukan yang amat penting dalam bidang kesihatan awam. Hadirin dan dihormati sekalian, SMILE 5.0 bukan sekadar sebuah program tahunan, tetapi merupakan platform yang mengintegrasikan pendidikan, khidmat masyarakat dan perkongsian ilmu dalam satu ekosistem yang menyeluruh. Dengan tema Empowered Older Adults, Inspiring Generations, program ini mengenengahkan kepentingan memperkasa warga emas agar mereka dapat menjalani kehidupan yang lebih sihat, bermakna dan berdikari. Di samping terus menjadi sumber inspirasi kepada generasi seterusnya. Tema ini juga selari dengan aspirasi negara untuk memperkukuhkan agenda penuaan sihat dan mempersiapkan masyarakat dalam menghadapi perubahan demografi ke arah sebuah negara menua. Cabaran kesihatan pada masa kini semakin kompleks dan tidak lagi boleh ditangani oleh satu disiplin atau satu profession secara bersendirian. Pendekatan interprofesional, kolaborasi rentas sektor dan perkongsian kepakaran merupakan antara elemen penting dalam membangunkan penyelesaian kesihatan yang lebih berkesan, mampan dan relevan dengan keperluan masyarakat. Dalam konteks ini, universiti memainkan peranan penting sebagai pemudah cara yang menghubungkan para penyelidik, pembuat dasar, profesional kesihatan, pihak industri dan komuniti dalam satu ekosistem ilmu yang saling melengkapi. Siri webinar dan podcast SMILE 5.0 merupakan manifestasi kepada pendekatan tersebut. Keseluruhan siri ini telah dirangka sebagai satu perjalanan ilmu yang saling berkaitan, bermula dengan memahami kepentingan penuaan sihat atau healthy aging, diikuti dengan perbincangan mengenai pembangunan dasar, penambahbaikan sistem penyampaian perkhidmatan, pembangunan tenaga kerja serta pemerkasaan komuniti. Pendekatan ini mencerminkan keperluan untuk melihat sesuatu isu kesihatan daripada pelbagai perspektif sebelum diterjemahkan kepada strategi, cadangan dan penyelesaian yang praktikal. Saya amat berbangga kerana siri webinar dan podcast SMILE 5.0 berjaya menghimpunkan barisan panel yang mewakili pelbagai sektor dan institusi. Antaranya, Program Kesihatan Pergigian Kementerian Kesihatan Malaysia, Jabatan Kebajikan Masyarakat, Hazanah Research Institute, Galen Center for Health and Social Policy, Institut Penyelidikan Penuaan Malaysia atau MyAgeing, Association for Residential Aged Care Operators of Malaysia atau AGECOP, serta pakar antarabangsa daripada University of Otago, New Zealand dan Health Sciences University of Hokkaido, Jepun. Pelibatan barisan panel daripada pelbagai institusi dan negara ini merupakan satu penghormatan kepada Fakulti Pergigian UiTM. Lebih penting lagi, pelibatan ini membuktikan bahawa agenda kesihatan awam dapat diperkasakan melalui jaringan akademik dan profesional yang merentasi disiplin, institusi dan sempadan negara. Saya berharap agar platform seperti SMILE 5.0 akan terus menjadi pemangkin kepada lebih banyak kolaborasi strategik, penyelidikan bersama, pembangunan inovasi, penerbitan ilmiah dan pembangunan kapasiti yang dapat memberi manfaat kepada masyarakat. Hadirin yang dihormati sekalian, akhir kata saya sekali lagi mengucapkan tahniah kepada program Doktor Kesihatan Pergigian Awam serta seluruh jawatan kuasa penganjur, para panel jemputan, moderator dan semua peserta yang telah bersama-sama menjayakan inisiatif ini. Semoga program SMILE terus berkembang sebagai sebuah platform akademik yang memperkukuh budaya perkongsian ilmu, menggalakkan kolaborasi strategik serta menyumbang kepada pembentukan masyarakat yang lebih sihat, sejahtera dan inklusif. Sekian, wabillahi taufiq wa hidayah. Wassalamualaikum warahmatullahi wabarakatuh dan terima kasih.
Terima kasih diucapkan kepada yang berusaha, Profesor Madya Dr. Masralis Ahmad tadi. Pergi ke kota membuat halwa, ungkapkan mesra, satukan jiwa. Penonton yang dihormati, tibalah kita ke kemuncak acara. Majlis dengan penuh hormat dan penuh takzim menjemput dan juga mempersilakan Yang Berhormat Datuk Hajah Hanifah Hajar Taib, Timbalan Menteri Kesihatan Malaysia untuk menyampaikan ucapan dan seterusnya merasmikan majlis perasmian siri webinar dan podcast SMILE 5.0. Dengan penuh hormat, majlis mempersilakan.
Bismillahirrahmanirrahim. Terima kasih pengacara majlis yang berusaha Profesor Madya Dr. Mas Suryalis Ahmad dekat Fakulti Pendidikan UiTM Sungai Buloh, yang berusaha Profesor Dr. Budi Aslini Muhammad Sabri, pengarah program Doktor Kesihatan Pendidikan Awam, yang berusaha Dr. Nur Amalina Hani Senin, pengarah program SMILE 5.0, barisan pengurusan universiti dan fakulti, para panel dan moderator, siri webinar dan podcast SMILE 5.0, warga akademik, para profesional kesihatan, para peserta serta hadirin yang saya hormati sekalian. Assalamualaikum warahmatullahi wabarakatuh, salam sejahtera dan salam Malaysia Madani. Alhamdulillah, marilah kita bersama-sama memanjatkan kesyukuran kehadrat Allah SWT kerana dengan limpah izin dan kurnianya kita dapat bersama dalam majlis perasmian siri webinar dan podcast SMILE 5.0. Saya ingin merakamkan setinggi-tinggi penghargaan kepada Universiti Teknologi Mara, khususnya Fakulti Pendidikan dan para pelajar program Doktor Kesihatan Pendidikan Awam atas komitmen menganjurkan program ini. Hadirin yang saya hormati sekalian, majlis kini sedang melalui satu perubahan demografi yang signifikan. Berdasarkan unjuran Jabatan Perangkaan Malaysia, negara dijangka mencapai status negara tua menjelang 2030. Apabila dianggarkan 15.3% daripada jumlah penduduk berumur 60 tahun dan ke atas. Melangkah ke fasa negara tua bukan sekadar tentang menyediakan rawatan hospital, tetapi menguji kemampanan perlindungan sosial, produktiviti dan pencegahan penyakit negara. Komitmen ini mengingatkan kita bahawa agenda penuaan sihat tidak boleh digalas oleh sektor kesihatan secara bersendirian. Ia memerlukan pendekatan whole of government dan whole of society dengan penglibatan kerajaan, institusi pengajian tinggi, industri, organisasi masyarakat, perkhidmatan, keluarga dan komuniti. Hadirin sekalian, kita harus sedar kesihatan mulut mencerminkan kesihatan tubuh badan. Kehilangan gigi yang menjejaskan fungsi kunyahan akan mengakibatkan isu malnutrisi sekaligus meningkatkan beban penyakit kronik yang lain. Pemekasaan komuniti amat kritikal agar masyarakat tidak hanya sekadar hidup lama, sebaliknya mampu melihara kualiti hidup dan tersenyum sihat di usia senja. Dalam konteks Malaysia, reformasi ini dipandu oleh aspirasi Agenda Nasional Malaysia Sihat yang menggalakkan seluruh rakyat mengamalkan gaya hidup sihat melalui pendekatan sick care kepada healthcare, penekanan kepada kesejahteraan, pengesahan awal dan menggalakkan gaya hidup sihat bagi mengurangkan beban pada fasiliti hospital. Dalam kerangka ini, kesihatan mulut tidak boleh dipisahkan daripada kesihatan keseluruhan. Selaras dengan aspirasi program kesihatan pergigian Kementerian Kesihatan Malaysia, melalui kempen 60-20 atau 20 teeth at 60. Setiap individu digalakkan mengekalkan sekurang-kurangnya 20 batang gigi asli yang berfungsi apabila mencapai usia 60 tahun. Perkara yang perlu juga diambil perhatian adalah berhubung pemberian perkhidmatan dan layanan supaya warga tua tidak merasa takut atau segan untuk mendapatkan rawatan gigi. Antaranya dengan meredakan ketakutan dengan memberikan rawatan yang paling selesa dan layanan yang baik. Perkhidmatan dengan memberikan galakan penjagaan gigi jangka masa panjang perlulah bermula dari awal. Penjagaan gigi yang betul akan memberikan peluang supaya kita dapat menikmati makanan tanpa dipengaruhi oleh gigi yang tidak sihat. Sebagai contoh, boleh menikmati makanan seperti daging dan lemang terutamanya di musim perayaan. Selain itu, dapat memberikan keyakinan diri dengan senyuman manis apabila memiliki gigi yang lengkap dan juga dapat memastikan perbualan harian adalah lancar. Hadirin yang saya hormati, bagi mendepanai cabaran hari ini, pembentukan dasar kesihatan wajib dipandu oleh data yang tepat dan realiti sebenar di lapangan. Hasil penyelidikan tidak boleh sekadar tersimpan di dalam jurnal ataupun bilik kuliah. Ia mesti diterjemahkan terus kepada bentuk perkhidmatan dan pelaksanaan polisi yang membawa impak nyata kepada kehidupan rakyat. Justeru, saya menyambut baik penganjuran siri webinar SMAL 5.0 yang menghimpunkan pembuatan dasar, ahli ekonomi kesihatan, penyelidik, ahli akademik, profesional kesihatan, penyediaan penjagaan warga emas, organisasi, masyarakat sivil serta wakil komuniti. Penglibatan pakar dari luar negara seperti New Zealand dan Jepun dalam webinar ini membuka ruang kerjasama antarabangsa yang amat berharga, di mana kita bukan saja dapat menilai formula terbaik negara luar untuk disesuaikan dengan acuan Malaysia. Hadirin sekalian, program ini menghubungkan kesihatan mulut dengan kesihatan umum, penuaan sihat, pembangunan tenaga kerja, reformasi perkhidmatan, pelancaran dasar serta pemekasaan komuniti. Inisiatif sebegini mencerminkan peranan penting institusi pengajian tinggi sebagai rakan strategik kerajaan. Ini bukan sahaja berperanan menghasilkan ilmu dan melahirkan graduan, tetapi juga menjadi ruang penemuan antara penyelidik, pembuat dasar, pengamal profesional dan masyarakat bagi menghasilkan penyelesaian terhadap cabaran keseluruhan kesihatan negara. Akhir kata, syabas dan tahniah juga saya ucapkan kepada Universiti Teknologi Mara, Fakulti Pergigian, para pelajar program Doktor Kesihatan Pergigian Awam, seluruh jawatan kuasa penganjur, para panel dan semua pihak yang telah menjayakan inisiatif ini. Semoga siri webinar dan podcast SMAL 5.0 menjadi platform yang mencetuskan ilmu, menggerakkan kerjasama dan seterusnya menyumbang kepada pembentukan sebuah Malaysia yang lebih sihat serta bersedia menghadapi perubahan demografi negara. Dengan lafaz Bismillahirrahmanirrahim, saya dengan sukacitanya merasmikan siri webinar dan podcast SMAL 5.0. Sekian, wabillahi taufiq wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh. Terima kasih.
The market increased from 0.5 billion in 2012. It has gone to nearly 4 billion now.
fascinating. You know, I went around all these old.
Get another second opinion. You know what to clarify, what to.
1,000 lebih 1.6% yang
and do other things. Okay. Have a good relationship with other people. Ini mungkin menyebabkan peningkatan.
audit bukan saja di tempat kerja, tapi audit di rumah.
Alhamdulillah, selesai sudah majlis perasmian siri webinar dan podcast Smile 5.0 Anjuran Fakulti Pergigian Universiti Teknologi Mara. Majlis merakamkan setinggi-tinggi penghargaan dan terima kasih kepada Yang Berhormat Datuk Hajah Hanifah Hajar Taib, Timbalan Menteri Kesihatan Malaysia di atas kesudian menyampaikan ucapan dan merasmikan program ini. Dengan mengangkat tema Warga Emas Perkasa Inspirasi Generasi, program Smile 5.0 kali ini memfokuskan kepada isu kesihatan pergigian warga emas melalui 7 aktiviti utama yang telah dan sedang dilaksanakan. Pertama, latihan Duta Smile telah berlangsung pada 16 Jun yang lepas bertujuan untuk melatih secara khusus seramai 10 orang warga emas berkenaan kesihatan pergigian warga emas. Mereka ini akan memainkan peranan penting semasa program komuniti nanti. Kedua, program ziarah kasih. Pada 3 Julai yang lalu, pasukan kita telah menyantuni warga emas yang terlantar di rumah mereka. Aktiviti ini dijalankan sebagai satu usaha kajian status kesihatan mulut dan pemakanan mereka di samping menyampaikan sumbangan ikhlas daripada pihak penaja. Ketiga, program komuniti telah pun berlangsung pada 11 Julai yang lepas di Pejabat Penyelaras DUN Sabak. Program komuniti yang melibatkan pameran kesihatan hasil kolaborasi bersama pelbagai agensi ini turut memuatkan pelbagai aktiviti menarik seperti pertandingan memasak, demo masakan sihat, pertandingan karaoke dan pertandingan mewarna. Keempat, aktiviti virtual run. Bagi menggalakkan gaya hidup sihat dan cergas, aktiviti dan sihat dalam kalangan masyarakat, aktiviti larian maya ini telah dilancarkan secara meluas melalui aplikasi BookDoc. Kelima, pendidikan digital. Seiring dengan perkembangan teknologi, 2 aplikasi digital mesra warga emas telah dilancarkan sebagai rujukan panduan kesihatan mulut. Malah, laman web rasmi smileuitm.com kini dilengkapi dengan ruangan khas panduan penjagaan serta sistem chatbot interaktif untuk menjawab sebarang kemusykilan mengenai kesihatan mulut warga emas dengan pantas. Keenam, pertandingan video TikTok. Bagi menyebarkan kesedaran secara kreatif, pertandingan video pendek di platform TikTok turut dianjurkan dengan mengetengahkan mesej dan tema utama kita iaitu memperkasa warga emas, inspirasi generasi. Ketujuh, siri webinar dan podcast. Siri webinar dan podcast yang sedang kita sertai sekarang yang bertujuan untuk mengupas dengan lebih mendalam isu-isu kesihatan pergigian awam semasa serta berkongsi ilmu secara interaktif bersama pakar dan masyarakat. Melalui integrasi aktiviti komuniti, kebajikan dan teknologi digital ini, program Smile 5.0 dipersembahkan untuk mengukuhkan mesej dengan memberi motivasi kepada golongan warga emas tentang kesihatan pergigian mereka yang baik adalah inspirasi kepada generasi seterusnya. Para penonton yang dihormati sekalian, majlis perasmian ini hanyalah permulaan pada siri ilmiah yang penuh bermanfaat. Siri webinar dan podcast Smile 5.0 yang telah bermula pada hari ini hingga 24 Julai 2026 menampilkan pelbagai pakar dari pelbagai bidang akan bersama-sama membincangkan secara menyeluruh isu-isu berkaitan kesihatan pergigian warga emas. Siri webinar dan podcast ini terbuka kepada orang awam dan disiarkan secara langsung di saluran rasmi YouTube Smile UiTM @SmileUiTM450. Untuk sebarang maklumat lanjut berkaitan siri webinar dan podcast program Smile 50.0, boleh dilayari di laman sesawang rasmi kami www.smileuitm.com. Para penonton yang dihormati sekalian, sebelum saya melabuhkan tirai majlis pada hari ini, siri webinar kita akan diteruskan dengan siri webinar 2 yang akan diadakan pada esok hari, 21 Julai 2026, jam 9.30 pagi dengan tajuk The Policy Roadmap, Crafting the National Policy Roadmap for a Healthy Aging. Bagi yang ingin mengikuti siri webinar dan podcast program Smile 50.0, anda diingatkan untuk mendaftar melalui kod QR di pautan yang tertera di setiap siri webinar. Saya bagi pihak majlis ingin mengucapkan ribuan terima kasih kepada semua pihak yang terlibat secara langsung maupun tidak langsung dalam menjayakan majlis perasmian siri webinar dan podcast program Smile 50.0 anjuran Fakulti Pergigian Universiti Teknologi Mara pada tahun 2026. Juga tidak dilupakan kepada seluruh ahli jawatan kuasa yang bertungkus lumus menjayakan majlis pada hari ini. Inilah yang diumpamakan, umpama belayar telah sampai ke pelabuhan, umpama berkayuh telah sampai ke haluan, dan umpama berjalan telah sampai ke tujuan. Ada mata, pandanglah keindahan, ada mulut, berbudilah pertuturan, ada hati, berilah kesayangan, ada salah dan silap, sudilah maafkan. Kerana tidak dinamakan laut jika tidak bergelora dan tidak dinamakan manusia jika tiada salah silap serta dosa. Saya Dr. Muhammad Firdaus Mokhtar, pengacara majlis hari ini, mohon mengundur diri. Assalamualaikum warahmatullahi wabarakatuh.
Senyumlah selalu, ceria berseri, 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni, Smile 5.0 membawa inspirasi. Senyumlah selalu, ceria berseri, 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni, Smile 5.0 membawa inspirasi. Senyumlah selalu, ceria berseri, 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni, Smile 5.0 membawa inspirasi. Membawa inspirasi. Senyumlah selalu, ceria berseri, 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni, Smile 5.0 membawa inspirasi. Senyumlah selalu, ceria berseri, 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni, Smile 5.0 membawa inspirasi. Senyumlah selalu, ceria berseri, 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni, Smile 5.0 membawa inspirasi. Membawa inspirasi. selalu ceria berseri, 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni, Smile 5,0 membawa inspirasi. Senyumlah selalu ceria berseri, 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni, Smile 5,0 membawa inspirasi. Senyumlah selalu ceria berseri, 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni, Smile 5,0 membawa inspirasi. Membawa inspirasi. Senyumlah selalu ceria berseri, 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni, Smile 5,0 membawa inspirasi. Senyumlah selalu ceria berseri, 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni, Smile 5,0 membawa inspirasi. Senyumlah selalu ceria berseri, 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni, Smile 5,0 membawa inspirasi. Membawa inspirasi. Senyumlah selalu ceria berseri, 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni, Smile 5,0 membawa inspirasi. Senyumlah selalu ceria berseri, 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni, Smile 5,0 membawa inspirasi. Senyumlah selalu ceria berseri, 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni, Smile 5,0 membawa inspirasi. Membawa inspirasi. Senyumlah selalu ceria berseri, 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni, Smile 5,0 membawa inspirasi. Senyumlah selalu ceria berseri, 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni, Smile ceria berseri 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni Smile 5.0 membawa inspirasi, membawa inspirasi. Senyumlah selalu, ceria berseri 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni Smile 5.0 membawa inspirasi. Senyumlah selalu, ceria berseri 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni Smile 5.0 membawa inspirasi. Senyumlah selalu, ceria berseri 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni Smile 5.0 membawa inspirasi, membawa inspirasi. Senyumlah selalu, ceria berseri 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni Smile 5.0 membawa inspirasi. Senyumlah selalu, ceria berseri 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni Smile 5.0 membawa inspirasi. Senyumlah selalu, ceria berseri 20 gigi di usia 60 nanti. Untuk kau dan aku bersama harmoni Smile 5.0 membawa inspirasi, membawa inspirasi. Senyumlah selalu, ceria berseri 20 gigi di